Good morning and welcome. I'm so excited you're able to join us here this morning for our first ever virtual conference. I am Barbara Fleck, the Executive Director of the Parkinson's Association of Northern California. I am excited about the program that we have put together for you today and all the presenters who have given of their time to put this together. We're also very grateful to our loyal sponsors, without which we wouldn't be able to be here today. So please thank them and check them out in the exhibit hall. If you registered before October 12th, you should have received your conference gift, which included a wristband, the conference printed program, and a copy of Shaky Hands, A Kid's Guide to Parkinson's Disease, written by our keynote speaker, Dr. Sonia Mather. If you didn't register by then, you should still receive a packet, and if you don't receive your packet, please call PANC. I hope you'll stay with us all the way through to the noon hour. We are offering a case study session sponsored by Boston Scientific. The topics to be covered include dyskinesia, deep brain stimulation, and movement disorders. I'm sure you'll find that information very valuable and insightful. While you're enjoying the conference, I want to invite you to come on our scavenger hunt. As you tour the virtual exhibitor hall, which you can do by clicking on the exhibitor hall icon in the left of your screen, please look for the scavenger hunt codes in each booth. The code is in the company description box. Save at least 4 of those codes, and when you receive our survey email, write those codes on your response, and you will be entered into our drawing to win. Several prizes are available. Those prizes include a set of Nordic walking sticks from Nordic Walking Nations valued at $145, $200 gift certificates for free exercise sessions with Rocksteady Boxing Warrior Fit, and 4 beautiful gift baskets from Once Again Creations, and thank you to all of our donors for those prizes. During the conference, if you have a question, please submit one by clicking on the Ask a Question button on the right side of the screen. Type your question and enter. We have people on hand to answer your questions. We also will provide a summary of questions and answers following the conference. It is now my pleasure to welcome our board president, Mr. Sean Tracy. Welcome, Sean.
Good morning. Good morning, Parkinson's community. Good morning to all of you out there attending this year's 2020 annual conference. This is our first virtual conference. I wish we were all together, but this is what we're going to need to do in this season of COVID. We are going to have to be together. We're going to have to work together, and we're going to have to make our whole lives a whole lot better together. So thank you for being here today. You've got a great conference ahead. This is one of the largest Parkinson's conferences in the nation. And I'm so pleased to say that today, PANC goes international. You're going to hear from Dr. Mather, who is Ontario, Canada, and we're here in Roseville, California. So PANC not only takes care of Northern California, PANC not only takes care of California or the United States, we're going international. So big year this year for PANC, big year for you. So my name's Sean Tracy. I've served as the president for the Parkinson's Association, proud to be a member of the board. This is an awesome board and an awesome opportunity to be here with you today and post this conference and help with education, training, enthusiasm, and inspiration for the days ahead. As I said, I wish we were here together. I could see you out in this audience. I can hear you. I can see the laughter. I can see the exchanges. What town you're from? Where are you coming? What are you going to do? What support group are you part of? I know you're there. So we're going to do this virtually this year. Next year, we're going to be back here in Roseville, and maybe we'll do both virtual and in person. Let's keep our fingers crossed, keep those doctors working hard, keep those research firms finding a cure, getting that vaccine out. We'll be back together. So we're all practicing public safety precautions. We're here together, and I hope that if you're at home with a group, do the same thing. Masks, social distancing, wash your hands. We've got so many lessons in that, and I know all of you at home have been so diligent and so resilient about making it through this COVID season. So proud of you, really are, and I know it's tough. So let's have some fun together today, and let's make this a conference memorable and something that you will treasure and something you will look back on through our website or through some of these video clips that really are going to be some valuable information. So we're trying to build community through the journey. Today's conference, we've got over 500, probably over 550, maybe 600 people who are here together virtually, and we're hoping that they have family members and neighbors and whomever in their homes watching this to learn, become educated, and help us move forward to find that cure that we know is out there. You know, together as this community, you're going to see today, you're going to see so many people who are so smart and so dedicated to you and to the Parkinson world about finding a cure, finding treatment, changing the game so that you have a better life, so that your family members have a better life, so care providers have a better life. We're all in this for you. And it's funny, you take a look at this, our logo here, and it's about being together. And I'm going to do a little presidential alphabet soup on you. Some would call it a V, some would call it a K, some may call it a W. I call it a U. This is all about you right here. That's why we're here today. This is about making sure you get the information you need and making sure you have resources so that you can live this journey the best way possible. You know, this year has been a unique year. It's been really amazing, a difficult COVID season, but it's been also an opportunity that we've never seen before in terms of the Zoom and the virtual connections and people's determination to stay connected together. And you know, at PANC, we love our organization. We think, you know, we're rocking it. But I also want to say we can't do this without our partners. We have such great partners in the larger community of Parkinson associations and organizations. And again, I'm going to go back to the letter. It's about you. Stanford, the PMDA Alliance, Brian Grant Foundation, Michael J. Fox, Parkinson Foundation. All of those groups, we work with them to make sure you get what you need for your life, to improve your circumstances, and to learn more about this disease and how we're going to find a cure. You know, together as a community, we establish identity through the work of leaders, we establish a foundation, we create vision, and we devote countless hours of service. Our board is a volunteer board. We work off your donations. We are so grateful this year that we have a grant from the Parkinson Foundation, first time ever. We are so grateful that they are our partners. We're going to be expanding our services to Northern California, to places where we couldn't get before, but the technology now has allowed us to get there. So grateful to them. Grateful to the Parkinson Movement Disorder Association, PMDA. We had a facilitators workshop. They had their very first virtual training, and PANC was their first customer. It was awesome. We really learned a lot. It worked well, and just like this conference, you kind of think, is it going to work for me? It's a virtual conference. I miss being with people. It works. Stick with us. You're going to learn a lot today. And it's not only about partners outside of PANC, but internally, we've got a really phenomenal group of medical leaders called the Medical Advisory Panel. And I like to think of this as the only one in the nation. Other people say, well, there's probably other groups who do this, but in Sacramento, in this region, our 4 major medical programs, Kaiser, Sutter, Dignity, and UC Davis, they all work together to take a look at how we're delivering Parkinson's care. They take a look at treatment alternatives. They take a look at new medications, and they talk to one another. Oh, that's easy, right? Not a big deal. Anybody who works in the medical community, works in business, works in government, knows that when you have competing systems and competing people working for a cause, sometimes communication is a little difficult. But thanks to Dr. Kandar and so many people on our board, that group gets together and really works, again, for you. And also really, really pleased and proud of the board of directors we have. You know, boards, you kind of can have good boards, you can have boards who get along well. This board is so committed to you, and they bring such amazing talents. We got physical therapists, we got fund development people, we got administrators, we got communicators, we got doctors, we got psychiatrists, we got medical doctors on our board. And through it all, we really find a way to maybe have our differences, maybe think about what are the alternatives, but we absolutely come together for you. And I'll give you a little story because in February and March, when we began to plan this conference, yours truly was saying, we are going to meet in person. This thing is going to burn off in the summer. We'll see everyone in October. Well, the board was wiser. The board really thought that through and said, well, let's just plan for virtual in case. Thank goodness we have a wisdom of 13 board members who got us to where we're here today. So here's my deal for next year. We're going to get through this thing. We're going to find a vaccine. We're going to be here in person, and we're going to be virtual, and we're going to be international. So hold me to that. That's my pledge to you. And the board's going to hopefully back me up on that. But anyway, it'll be good. So we wanted to pivot into this virtual conference, and we got the conference committee members together. They've worked tirelessly to bring together this conference for you. So many people. And I'd really like to talk about Barbara Fleck, who is our executive director. She came to us. We hired her in April. We hired her as the executive director. First assignment was, hey, let's have our annual conference in October. Only 600, maybe 1,000 people are coming. Can you do that? And that's where we're at today. So Barbara can't do that alone with Sharon Danelli-Waraday and a couple of board members. We really had to pull in some great business partners. The events group from Heather Tinfani and Georgia Fox Waters, the Extreme Video team that's here today, they are making this all happen for you. So the quality of this, the delivery of this, it's all a huge team effort. And in addition to business partners, we have to look at elected officials, those folks who make policy, funding decisions. And so there are a few people we'd like to say thanks to in terms of the political and governmental and elected officials world. And we'd like to share a special announcement from one of them now.
Hi, I'm Congressman Ami Bera. It's my privilege to welcome participants and folks who support the Parkinson's Association of Northern California and help support patients with Parkinson's disease as well as the families. As a doctor, it's incredibly important for us to take care of these patients, particularly in the midst of this pandemic. Also, as a member of Congress, it's important to support efforts like the Brain Health Initiative and continue to fund research so one day we can find a cure for Parkinson's disease. Everyone, be safe during this pandemic, be kind to one another, and we will get through this together. Be well. Thank you.
We've had a couple of representatives in the state legislature and in Congress who have really sat down with us and thought about how we could partner and work together towards common goals. They understand the Parkinson's community, folks who really understand what we need and how they can help. So there are a few who have helped us in that regard, and we'd like to just mention their names briefly. So Congressman Bera and Senator Richard Pan, Assemblyman Jim Wood, and then also Nadir Azarian out of the San Fernando Valley. And Assemblyman Nazarian was responsible for the extension of the Parkinson's Disease Registry, which is huge for this community. So thanks to them. And yes, good policy happens. Yes, good public officials are out there. And when you see them, and if you're in their district, say thank you. A community needs vision. And for PANC, there's a vision we share for 2020. We want to do more. We want to have more support groups. We want to have more respite. We want to have more Parkinson-wise programs. We want to have more engagement with the Parkinson community throughout Northern California. And particularly, we're looking at ways to reach out beyond the Sacramento region and into the northern part of the state, into rural and underserved communities throughout the northern part of California. And with this new technology, with the Zoom and with the ability to do these video conferences, we're not stopping there. We're looking at all of California. We're looking at all of America. We're looking at the international community because we can offer up things that might be helpful to those groups and vice versa. So we are really pleased that we're going to expand our vision, and we hope you're going to be a part of that. We are rebuilding together programs. We are care partners. We are looking toward, as I said, and hold me to it, a bigger conference here at the Placer Valley Center. We can have thousands of people in there. We can have it virtually, and we can have it in person if this all works out the way we expect it to. So look forward to seeing you there. And you know, during this COVID season, so much, it's been a tough year, right? It's really been a difficult time, and there's been loss. And we've lost connections, we've lost the ability to move about, we've lost the ability of some of our economic engines. We've lost some things, and we've lost some people along the way. And really, you know, I'd like to just call out people who have made a difference in our support group. So Part of the Ardent Arcade support group was a gentleman named Leo Warmitz. Leo was an outstanding public servant, a consultant, a great family man, an athlete, tennis player, and he was always at the Ardent Arcade support group with his wife, Joyce. Leo passes here. And then also in our group, in our little Northeast nomads, we got a group of about 15. We have a group of folks called the Gigliotti family. So I call them the Three Musketeers. So Richard's a husband, Marlene's a wife, and Cindy's a daughter. Every meeting they come to us with their canes. They come to us with the canes, and we pulled them up and we call them the Three Musketeers. But they were so engaged. They were so involved and supportive of our support group, and we meant a lot to them. We lost Marlene this year. So we're all dealing with a little bit of loss, but we're dealing with more hope. We're dealing with more resilience. We're dealing with more, we're going to get through this. And this conference is going to help and is going to show you we can get through this. And how can we get through this? Go ahead, show the sign. Together. We're going to get through this together. So thank you for all you do. Thanks for being a part of this community. Take a moment for all of us, just a quiet moment to think about those we may have lost and those we miss. And you know what they're telling us? They're saying, keep going. Don't give up. This fight is not over. As Michael J. Fox said in his recent webinar, he said, you know, I've got Parkinson's. I was diagnosed at 29. If you're diagnosed at 29 now, you're going to see a cure. I promise you that. And I believe him. And I think the cure is in our future. So in honor of those who we lost, in the future we're going to have a great day together. We're going to have a great, awesome day together. And thank you for being here and spending your Saturday with us at the Parkinson's Association of Northern California. So it's my honor, and I want to introduce a board director. In my mind, that's is the most important job, not his job. He's a doctor at Kaiser Permanente, well known around the world for his experience, expertise in the Parkinson world. So we're going to have coffee with Dr. Suketu Kandar, and I like to call Suketu the sage, because in our meetings and in our discussions around different issues and things, we'll have our fights. We'll be fighting and be rattled back and forth, chat, no, I disagree. And then Suketu comes in and just says a few words. I think we might look at it this way. And that coffee with the doctor seems to always solve those problems. So I want to introduce you to Dr. Kandar, and he's here today to have a little coffee talk with you. Thank you, Dr. Kandar.
Thank you very much, Sean. I really appreciate the opportunity to be here this morning. And we've done something a little bit different than we've done in the past. So this I'd like to call Coffee with Kandar. See, I got my coffee mug over here. And look at that, there's actually a PANC logo on this. I'm totally keeping this afterwards. So when many of you audience members registered, you were given the opportunity to ask questions of not just the panel, but also of myself. And I would like to thank our organizing committee to having sifted through hundreds of questions, coming down and paring it to just a few that we could answer here today that we thought would be most beneficial to our audience. As a movement disorder neurologist, I'd like to think I've had a little bit of experience when it comes to treating those living with Parkinson's and their care partners, but I certainly don't know all the answers. I will go through these questions, answering them to the best of my ability, and I'm going to ask for your forgiveness in advance in case I'm not entirely not as expert on that question as possible. So let's go ahead and begin. So first question we have is, what should a visit with the neurologist look like with young onset Parkinson's disease? I'm going to go ahead and broaden that question to what should an office visit look like with anybody living with Parkinson's disease? And this is where I'd like to put a little bit of ownership, not just on the patient and the provider, but also on the patient's family. I think that a patient should become prepared when they come to the office visit. Oftentimes when a patient comes to the office, we almost always sit there and focus on just the motor symptoms, right? So if you think back to what are the motor symptoms of Parkinson's, we got tremor, stiff movements, slowed movements. walking difficulties with imbalance. And oftentimes, if those are the things that you present to the provider is only going to focus on those things. But there's so many other things that somebody with Parkinson's might also be, what symptoms they might also be having, particularly non-motor symptoms, maybe difficulties with sleep, difficulties with depression, difficulties with anxiety, difficulties with swallowing, difficulties with GI symptoms, things like constipation, or urinary symptoms with increased urinary frequency, or how about pain or fatigue? All these things should also be addressed as well. Now, you might be wondering, well, how can I possibly address all these things in a 20 or 30-minute visit? This is why you want to go ahead and prepare a list before you come to the neurologist's office, a list outlining this is my number 1, number 2, and number 3 worst symptoms that I'd love to have addressed by the end of this visit. And that's what you want to bring forward to the physician. The other thing you can do to help prepare for a visit is bring a list of all your medications. Current medications that were prescribed, but also medications that you might be taking that's over the counter, maybe even supplements as well. And don't forget to review those medications and those supplements with your neurologist as well. That neurologist should not only review the questions and your concerns, but also review your medications, and then of course do a proper examination if need be, and then also set expectations about what they would like to do moving forward, as well as set expectations about when they should see you again, whether it be once a year or every 6 months. The neurologist should also be ordering labs if necessary, maybe even imaging studies if needed, but also let you know if other people need to be recruited into that team type approach. Maybe it be a physical therapist, a speech therapist, an occupational therapist, or if you're considering more advanced treatments like deep brain stimulation, seeing a neurosurgeon. So that's what you should expect from the neurologist. But as a neurologist myself, I also expect a certain degree of ownership from you as the patient, as well as the care partners to bring to my attention so we can optimize the visit. All right, on to the next question. Is it okay to have more than one neurologist? Good question. And I've always heard that cliche that, let's not have too many cooks in the kitchen. But if you look at neurologists today, it's really less than 5% of all neurologists in this country are specialty trained Parkinson's specialists. So it is not uncommon for a patient to have a general neurologist, maybe the one who actually made the diagnosis, but over time also require the secondary opinion and expertise of a movement disorder specialist or a Parkinson's specialist. So in that scenario, you may in fact have 2 neurologists. On the flip side, if you are someone who has one general neurologist and another general neurologist that you're seeing maybe in 2 different areas, it kind of gets a little bit confusing, especially if those neurologists don't talk, because again, going back to that cliche, too many cooks in the kitchen, you might get some information from one neurologist and a different set of information from another. Remember, Parkinson's disease is a designer diagnosis, one that requires tailored treatment. And it's an art form to treat Parkinson's, and there really isn't any good standard practice as to how we approach that care. So therefore, one neurologist may have a very different approach to how to treat Parkinson's, and another neurologist a slightly different approach. So for that, we really need to appreciate that maybe best having one general neurologist and possibly a movement disorder specialist when needed. So there's a question here about palliative care, long before hospice. I think for a lot of people in the audience, it's kind of unclear as to what palliative care is, and we often just kind of mentally equate palliative care to hospice. Hospice, of course, in the state of California is where you have comfort type care, particularly when one or maybe even 2 physicians believe that you as the patient may only have 6 months left to live in an untreatable, uncurable condition, and that's all. However, palliative care is much, much broader than that. And I probably heard it best from a palliative care expert that we've actually heard before through this PANC conference, Dr. Nathan Fairman out of UC Davis. And he said that palliative care really is a field of medicine that help people live better with their chronic condition. And palliative care also allows you to author the chapters of your life, not allowing anyone else to be your autobiographer. So that said and done, taking Dr. Fairman's sort of description, palliative care really should be deployed right at the time of diagnosis. And whether your neurologist or your primary care physician truly appreciates it or not, they're already acting as palliative care providers in a primary sense. They're the one who delivered the diagnosis. They're the one who set the foundation of what you need moving forward. And then getting palliative care, true palliative care involved maybe midway through your diagnosis would be important to make sure you have an advance directive, a post, and that people are quite aware as to what your wishes might be moving forward in case something, God forbid, were to happen. And it's not until much, much later into the condition that you may need things like hospice. But we clearly should not be evoking palliative care late. We should really be getting palliative care involved a little earlier. Next question, very relevant question, is given COVID-19 restrictions, many healthcare institutions moved into a virtual space. How effective are virtual doctor-patient meetings? So for this, we have to understand that the idea of telehealth is not new. It didn't just blossom because of COVID, although COVID really was a catalyst. People have been using telehealth now for over a decade. In fact, I remember writing an article for a prominent journal about 8-9 years ago in conjunction with the VA Medical Center and other very large organizations within and outside our country on the future utility of telemedicine, virtual visits, video care visits for Parkinson's disease in the future. At least my piece of it working at Kaiser Permanente was that I think it could be wildly useful. And there's certain scenarios, it may be better to use it almost as a stepping stone, a complement to future in-person appointments. Mentally, we all kind of think that you have to make a formal appointment with the physician, wait for that appointment to occur, walk into the clinic, wait in the big waiting room, then wait in the little waiting room, and then see the physician, and then you go through this sort of formal motion of giving your history, doing that formal evaluation, and then writing out what guidelines and recommendations the doctor wants for you. Well, it's the 21st century. And I think there's ways in which we can utilize virtual visits to our advantage. I see a lot of patients that are outside of the Sacramento Valley area, patients who may have to drive hours to come see us. How cool would it be if I could have my first visit with them virtually, soon after that referral was made, maybe within a week or two, giving that patient some time to prepare, but also giving me some time to understand their medical record, which now a lot of it is electronic. Then I can virtually visit with that patient in the settings of their own home, get an understanding, a baseline, a foundation of what's been going on, start to make some recommendations of maybe some labs or some imaging that I'd like to get for them, maybe make some recommendations on medication changes, and then afterwards, a few months later, see them in clinic. I find that that actually is quite optimal, not just for our remote patients, but maybe for those people living right down the street from where we work. So when I wrote that article, or at least contributed to that article years ago, I thought that there will be a future use of telehealth. And now, of course, with the COVID-19 restrictions, we've seen this expand quite a bit. At least in my clinic, and I can, of course, only speak to my clinic, I use virtual visits quite often for not only newly diagnosed patients living with Parkinson's, more patients with advanced Parkinson's disease who may be considering a higher level of treatment like deep brain stimulation or the duopa gel infusion. I see patients simply for a second opinion through the video visits or even for their follow-up visits. Now, of course, not everything can be done through a virtual visit. Some things do require you to come in. Part of the examination does require us to actually lay hand on you and be able to examine you in a more formal, appropriate way. But quite a bit of what we do in movement disorder neurology can be done virtually and done so successfully. How does a neurologist diagnose Parkinson's without meeting the patient? So I think we kind of answered that with the last one. And can a diagnosis be done on the first visit? The answer, plain and simple, is yes. So if you can think about by the time you see a neurologist, you've probably already developed some symptoms of Parkinson's, be it the tremor, which is very visible, some motor slowness, again, quite visible, some motor stiffness, which you can infer by watching somebody, and maybe some walking difficulties with stooped posture. Arguably, all of those things, with the exception of Parkinson-related rigidity, can actually be examined virtually. If you look at the last Parkinson Path newsletter, the one that you may have mailed to you or even sent to you by email, there was an article that was written in there about the utility of telehealth. and what are some of the things that we can do via video examination that gives us as providers insight into your condition. I can actually have a patient sit in a way that I'm sitting now with their hands sort of resting on their lap in order to monitor their tremor as they speak. I can have a patient get up from a seated position, open and close their hands or give me finger taps and measure that against the opposite side. I can have a patient walk down a well-lit hallway to see sort of the fluidity of their movement as they go down the hall, have them make a turn, safely of course, and walk back to me, giving me quite a bit of information and some insight as to whether they have clinical symptoms of Parkinson's. Remember, Parkinson's is a clinical diagnosis. It requires good history, good observation, and a good examination, most of which can be done virtually. There is no blood test for Parkinson's disease. There is no imaging study for Parkinson's disease. It relies on an expert eye. Next question. Describe the diversity of the Parkinson population that you treat in terms of age, gender, racial and language, etc. Do you notice disparities in access and awareness to Parkinson resources? And does your practice have any programs that address these disparities? Well, this is going to require me to have a sip of my coffee. So if any of you had the pleasure of actually watching the recent California Parkinson Disease Registry conference that was in partnership with the Parkinson Association of Northern California, you would be aware that we actually have a California State Parkinson Disease Registry. This was actually signed into law in 2018. And it's a requirement for all providers across the state, whether it be at my institution at Kaiser or at any of the academic institutions around us. It requires that all providers submit information about whether somebody has Parkinson's or not. Now, of course, I won't go into the details of what is submitted and how that information is protected. And again, I want to reassure our audience that this does not go to the DMV. But this information is done in an attempt to really understand the demographics of Parkinson's across the state. In the past, a few other states have also tried to have registries, but somewhat unsuccessfully. And certainly those states did not have and do not have the same sort of diversity that we do within the state of California. Arguably, California probably has a wider diversity than most other states do. And if you look at some of the epidemiological studies done about Parkinson's disease, a lot of them come from the Mayo Clinic in Rochester, Minnesota, which is in Olmsted County, Minnesota. Olmsted County is probably far less diverse than maybe Sacramento County is here. And so a lot of the original understanding of where Parkinson patients are or who Parkinson patients or who is affected by Parkinson's disease is based upon those original studies. And it'll be nice to see after a few years of dissecting the data that the California Parkinson Disease Registry comes up with and comparing it to the original Olmsted County, Minnesota studies that were done then. What we do know is that most people with Parkinson's are usually diagnosed around the late 50s, early 60s, although the incidence does go up with age. Number two, we see men slightly more affected than women, and we see Caucasians more affected than any other ethnicity. But if you start talking about awareness and sort of access for specifically certain groups within the Parkinson population, it is clear to me as a provider of over 15 years that ethnic populations as well as female gender are less likely to access healthcare than their sort of Caucasian counterparts are. And it's not clear to me exactly why that is. But I think that the National Parkinson Foundation here locally, the Parkinson Association of Northern California, has gone through great lengths to be able to make resources accessible to everybody. So at least I would feel that we're moving in the right direction, but a lot more to come regarding this particular topic. It was a very good question for the person who submitted it. Next question, moving on to treatments. Any new treatments available? Comment on preventive measures, early diagnosis, and future innovations for the treatment. So there's always new treatments available. When I did my fellowship training back in 2004, we were still relying on the old medications, right? Some sort of analog of levodopa, whether it be immediate release levodopa or long-acting levodopa. Some dopamine agonist like pramipexole or ropinirole. We were trying to navigate and juggle these medications, maybe a few medications that already come around that would help to extend the life of some of these medications. But the concept of things like ancillary medication use or polypharmacy, but more optimization of that polypharmacy, or medications for rescue therapy, for off treatment, or the utility of exercise had not really been studied and clearly had not been actually discussed with patients. I feel in the last 15 years, I've seen a huge ramp up, maybe thanks to celebrity patients like Michael J. Fox or Muhammad Ali that have really put a spotlight, not just on Parkinson's, but the need for research for Parkinson's. And for audience members like you really are going to be sort of the heart of that. I remember in that conversation that I had with Mark Damison, who's the director of the Parkinson's Disease Registry, something like only 3% of all patients living with Parkinson's ever involve themselves in research. So if we want to know about new treatments, they're not going to get approved by the FDA unless you also take some initiative in wanting to be a research participant, working with academic colleagues, and trying to come up with something more innovative for the future. What I'm most excited about is just in the last year alone, we've seen several medications get FDA approved. Medications that are not necessarily first-line agents, but medications that can really potentiate levodopa that you might already be on. I have also been very happy and pleased that over the last 5 years, we've seen a couple new device companies get FDA approval for when it comes to deep brain stimulation. And these are all things that all of the local as well as statewide organizations have been using. Any new therapies for fog? Now, I don't mean San Francisco fog, I mean freezing of gait. And you might actually hear this term from your medical provider. Freezing of gait is a very, very common symptom in Parkinson's where your upper body wants to move as you walk, but your lower body gets somewhat stuck to the ground. And you start to make these pitter-patter steps, or you may just simply get stuck. There's 5 ways in which somebody actually may have freezing. It's when you initiate your walking, so you get up from a seated position, try to start walking. You actually try to make a turn. You walk down a narrow hallway. You may actually try to see your destination but not be able to reach it, or you may go through a doorway. All these things may trigger a freezing episode. To date, there are no medications that are FDA approved for freezing. There are no CE mark medications in Europe that are approved for freezing. Freezing of gait is best treated through something called visual cues that are basically deployed and given out by physical therapists. So a good physical therapist that has training in Parkinson's disease treatment understands the utility of visual cues to overcome freezing of gait. And there are also certain types of assistive devices, specific walkers, for example, that also use these visual cues to overcome people's freezing. And they could be quite successful. Any updates on stem cell research? Actually, if you are a subscriber of the Parkinson Path, again, the quarterly newsletter put out by the Parkinson Association of Northern California, our next Parkinson Path has an article on stem cell research. So I urge you to actually, if you don't already get that newsletter, please call the Parkinson Association office so you can get that newsletter. But there's a whole nice article coming up on stem cell research, so I won't get into that now. Anesthesia and Parkinson's, what are the dangers? I always tell my patients that if you're going to undergo surgery, and often people do need surgery for things that are unrelated to their Parkinson's, if it's local anesthesia or spine anesthesia, I have no problem whatsoever. If it's general anesthesia, then we have to take notice that it may be that, by being exposed to a neuromuscular blocker, basically a paralytic, that in recovery, as you come out of that anesthesia, it may be a little bit harder for you to move. It may be a little bit harder for you to recover, and that recovery may be protracted. So just expect that post-operatively, it's going to take you a little bit longer to recover. And maybe there has to be a conversation between the anesthesiologist, the surgeon, and your neurologist. How can I reduce my off periods? Now remember, off time is when your medications are either wearing off, so you really got a good response from meds, but as it starts to wear off, you're starting to notice your motor symptoms return, and you're now waiting for your next dose to take or next dose to kick in. There are several medications that can help to promote improvement in off period or increase in your on time. And that can come through adjusting your current levodopa medications or dopamine agonists, or by adding medications to potentiate levodopa. And that might be a good discussion with your primary neurologist or your movement disorder specialist. Another thing to remember is that exercise can help to improve off time as well. Is restless leg syndrome part of PD and can it be treated? The answer is yes. So restless leg syndrome is absolutely something that many of our Parkinson patients get. I need you to understand that just because you have restless legs does not mean you have Parkinson's, but if you have Parkinson's, you're more likely to have restless legs. And it can be treated with some of the similar medications that we use for Parkinson's disease, be it a dopamine agonist like pramipexole or ropinirole. But before you get treated for restless legs, you may want to have your neurologist look into checking your iron levels. Oftentimes, low iron can be something that can be treated without the need of medications, and then you don't necessarily need to be on something specific for restless legs. Next question, how do we know about subtypes of PD? So again, I'd mentioned before at the beginning of this that Parkinson's is a designer disease. Right? So there are very different types of Parkinson's. If you go to a support group meeting, for example, although many of them now are virtual, you will notice that you may be a little bit different than the person sitting next to you, right? Everybody had it at a different age with different symptoms and different response to medications. Again, going back to that concept of designer disease. If I could subcategorize Parkinson's into three main categories, it would be that there's the garden variety Parkinson's, kind of what Dr. James Parkinson first described over 200 years ago, where people have equal parts stiffness, slowness, and tremor. But then there's also tremor-predominant Parkinson's, where people have tremor as their predominant symptom, and the other symptoms are not as prominent. And then flip side, there's something called akinetic rigid syndrome, where people are more rigid, more slow, and more stiff, but they don't necessarily have as much of a tremor. And that type of understanding really is where a movement disorder neurologist can help you better understand what type of Parkinson's you have and what medications may be best for you. What new medications are for Parkinson tremors and dyskinesias? Arguably, Parkinson tremor tends to be one of the most stubborn of all Parkinson's symptoms, one that doesn't really like to respond to medications. Kind of the reason why deep brain stimulation really came to light. So currently, there are really no medications specific for Parkinson tremor other than what we classically have in our arsenal. As for dyskinesia, however, there was a medication that came out back in the 70s, an old flu medication called amantadine. Amantadine has been repurposed time and again, but now has been looked at really in a long-acting form specific for Parkinson-related dyskinesias. For those of you who are worried that Parkinson medications may lead to dyskinesia, which are those involuntary sort of movements that people get when they're on medications, you know, sort of like a fish out of water, there are things that we can do to adjust your medications, so your worry about getting dyskinesia in the future should never really inhibit you from wanting to start medications. Because if you ever go to develop dyskinesia in the future, we can either adjust your levodopa and related medications or add medications like amantadine. And recently, the long-acting version of it was FDA approved. What benefits have you seen when patients switch to Rytary? You may have heard that name, Rytary. Rytary is basically a combo pill. It has both long-acting levodopa and short-acting levodopa, all kind of bundled into one capsule. And so the hope is by being on Rytary, maybe you can reduce your need of total daily dose of levodopa or reduce how frequently you take your medications. The one issue with this medication is that it's a little bit more, it's a little slower to be absorbed, so the absorption rate is not as predictable. Well, I take that back. It's not as good as it is with immediate release alone. So you'll have to work with your general neurologist or your movement disorder specialist on how much Rytary you need, because typically we have to increase the dose of Rytary relative to how much levodopa you were taking before. So this is going to be a little bit of a tough question. I have a client now with terrible Parkinson's dementia. He required protective supervision overnight. His wife can never leave him alone any longer. It happened very suddenly, which can be quite scary. He was pretty stable, and then last week he had a huge decline. We're trying to understand if this is medication-induced or is it just illness and progression. So one thing you need to understand about Parkinson's is that it's not a linear decline. It's actually a stepwise decline. You kind of plateau for a little while. Sure, it'll get worse with time, but it's pretty slow. And that's how most patients tend to progress. But there may come a point, maybe something triggered, where all of a sudden, boom, you don't do so well. It could have been an infection or a flu symptoms or a fall, something that triggered this worsening, this sudden worsening, which could be scary not just for you as the patient, but also for your loved ones. This clearly can happen more in advanced disease than it does earlier, and also in those people living with dementia and their Parkinson's. So when we see a stepwise decline like this, we really do need to investigate, is there underlying infection, dehydration, or something that triggered it? And first rule that out and treat it if it's there. Number two, are there things that we can do to help remedy that? Well, one is you can adjust the medications. Sometimes too much levodopa-type medications will make those matters worse. And there are medications to actually battle some of these things like hallucinations or worrisome symptoms that people develop with their dementia. So you're going to want to talk to your provider about that. Is there a way to slow progression in dementia? So this kind of takes me back. The chief of neurology at Stanford Medical Center is Dr. Frank Longo, who's an internationally recognized dementia specialist, not a Parkinson's specialist, but a dementia specialist. And he had gone on sabbatical once looking at all the different supplements and over-the-counter herbicides, pesticides, things that people have really brought to him saying, hey, can I try this for my dementia? And he wanted to investigate whether these things truly had evidence to support that, and found that really they didn't. The thing that really had the most evidence, however, to help reduce the symptoms of dementia, maybe even support some slowing of disease progression, was exercise. And if you think about it, it makes sense. The more you exercise, the more blood is going to be flowing. The more blood that flows, the more you're basically kind of watering the plants, if you will, up in the brain. And that's really going to help to promote better blood flow, better oxygenation, better nutrients that go to the brain, helping to support better thinking. So if there's any one way to stop or slow progression of dementia, it's basically getting out there and exercising and being active. I am reluctant to take another medication, but I should consider something for depression and negative emotions that I'm feeling. Should I take another medication? To have Parkinson's is really to be on a lot of meds, and there's no real good way about it. I'm not really much of a med prescriber, but there are times that I'm going to have to prescribe medications. And I think I would be remiss not to look at things like depression in a way in which, trying to treat it only conservatively. I think that there are times where my patients who are depressed, it may be a roadblock to successful treatment for them in the future. So if I don't look at depression and treat it, prescribe something for it, don't look at any negative emotions, treat it, prescribe something for it, I think we're going to actually lose out when it comes to optimizing their total care when it comes to Parkinson's. List 4 things to do if you have Parkinson's to have a better life. This is a great question. And if you stay tuned for the remainder of this program, I'm going to be asking a very similar question of our keynote speaker. Number 1, well, let me take a step back. A few years ago, the National Parkinson Foundation had asked me to do a worldwide webinar on Diagnosis Parkinson's Now What? And I tried to summarize what do you need to do in order to keep yourself really on your toes and kind of ahead of the game when it came to Parkinson's. Basically, what do you want to do to help improve your quality of life? Because we know, at least at this point in time, we don't have a cure for Parkinson's. We don't have something that's going to all of a sudden make your symptoms completely go away. But we certainly can treat your Parkinson's, and we certainly can give you a better quality of life. So it's kind of what this is getting back to. So going back to that talk that I gave, there were 3 things, 3 equally important things. Number 1, making sure you have the right diagnosis. Making sure we're dealing with garden variety, regular Parkinson's, or one of those subtypes that we previously talked about. Or do you have some atypical Parkinson's that requires a little bit more monitoring? And part of that same piece of the puzzle is, are you on the right medications? So 1/3 of the equation is right diagnosis with right medications, basically optimizing your medical treatment. But that's only 1/3. Another 1/3 is really going to be being on the right physical therapy program. And it's not just seeing your neurophysical therapist or a good speech therapist or a good occupational therapist. It's also having the right positive mindset, which also kind of brings me back to a book that Michael J. Fox wrote called Always Looking Up, which I don't know if it was really a take on him being short or was it the fact that he looked up in optimism. But the bottom line is, if you as the patient have a positive attitude, can you imagine how much more you could do through your visits with the physical therapist, or how much more you're likely to do at home? So another third of that better quality of life piece of the puzzle is good physical therapy, but really being honest with yourself and following through with it. And then the last piece of the puzzle is really ownership. How much do you own when it comes to your condition? This is not really for me to completely navigate you through. It's for me to help steer you a bit, but it's really for you to navigate yourself. How involved do you want to be? How much do you set the tone for your own quality of life? How often do you reach out to your neurologist? Maybe to support groups, to your local Parkinson Association, or to research opportunities. That degree of ownership is what I'd like to see a little bit more of in my own patient population. And if there's anything more that I could do to help promote that, I would love to. But those are the things that anybody living with Parkinson's needs to do in order to ensure a better quality of life, living better with your condition. What is being done to entice more medical personnel to specialize in Parkinson's? Not just neurologists, but other specialists as well. It's a great question. So I had mentioned before at the beginning of this program that, neurologists in general make up only 1% of all doctors in this country. Out of that 1% of all doctors, it's less than 5% that are movement disorder specialists. Even when I did my own training, Stanford didn't have a fellow at the time. UCSF had me as one fellow every 2 years, or one trainee every 2 years. UC Davis didn't have a fellow either. So in the whole Northern California area, I was the only fellow. Now UCSF actually has 3 fellows every year. Stanford has a couple of fellows, at least 1 per year, and so does UC Davis. So we've already increased the number of neurologists being trained in the specialty care of movement disorders. And I think that as a movement disorder neurologist, I have pride in that I'm seeing that my own field is growing. But I also see that colleagues who also are on sort of the sidelines of Parkinson care, whether it be neuropsychiatrists, other specialists in mental health disorders, therapists, counselors, neurosurgeons, are also seeing movement disorders as an opportunity of success. See, when I first did my training just in general neurology, neurology was the type of specialty where you can look like the hero by being very sort of astute and going through a detective type process to understand your condition. You were the hero for making the diagnosis, but there was very little you could do about that diagnosis, which kind of gave you sort of that pitting feeling in the sense of, in your gut that, gosh, I feel great that I made a diagnosis, but nothing I can do about it. But in movement disorders, in Parkinson's disease, there's so much that we can do. And I think that a lot of people going into training now recognize that and see it as a mark of success for themselves in their own careers. So to answer this question, which I think was a wonderful question, rest assured that we're seeing a lot more people coming out of training now, not just in neurology, not just in Parkinson's disease movement disorder fellowships, but also in other services as well, which is really going to hopefully open the door for multidisciplinary care and more coordinated efforts when it comes to how much of a team do you build to help support your patient living with Parkinson's disease. So these are some of the questions that you guys pitched to us. During this time, you also will be asked through the WOVA app that you can also ask questions as well. Many of the folks who are going to be speaking here today will be online today also helping to answer some of these questions. So I urge you, if your question was not answered during this time, or you have a burning question that you'd like to actually put in the chat box, it might be important for you to go ahead and put that question down, and hopefully one of our specialists in the area, whether it be from Sutter Health, Mercy Dignity, UC Davis, UCSF, Stanford, or at Kaiser Permanente, will be more than happy to answer. Now that said, it was enjoyable being here. I thank you for the opportunity. I thank Parkinson Association for the opportunity, as well as the organizing committee. And it's with great pleasure that I introduce our first speaker, Dr. Erica Bird. Now, I've known Dr. Bird for a little while now. She also trained at my alma mater at UCSF. She had originally gotten her MD or medical degree from the Medical College of Wisconsin, went on to do her residency at the University of Washington, and then her fellowship at UCSF in San Francisco. She was brought on board at Sutter Roseville and has been a wonderful complement to the movement disorder and neuroscience program that they had already developed at Sutter Sacramento. So a lot of the patients living out in the Roseville area and beyond can actually access her care or her delivery of care there in Roseville. Her practice includes Botox, deep brain stimulation, dystonia, essential tremor, Lewy body disease, other forms of movement disorders, Parkinson's and Parkinson-like conditions included. Please welcome Dr. Erica Bird, who will discuss sleep in Parkinson's disease.
Good morning. Thank you for that introduction, and thank you to PANC for inviting me to speak today. I'm excited to talk to you all about sleep and Parkinson's disease. Hopefully, I don't have to convince you too much about the importance of sleep. We all know how we feel when we have a good night's sleep or a bad night's sleep. When I was preparing for this talk, we were looking for a lot of cartoons involving sleep, and there were a ton of them. So you'll see throughout the talk a few snippets here and there. This one is from Dr. Kandar. Thank you very much. How will I sleep? At work, watching a movie, driving, and lying in my own bed at night. So this is a common scenario. I'm sure we can all relate to this. But sleep is very important for cognition, the way you think, your memory, your mood, your general well-being, gives you the energy to do the things that you need to do on a day-to-day basis. And most importantly, for Parkinson's, poor sleep can affect caregivers too, and it correlates with greater caregiver burden and decreased quality of life. So it's important that you're getting as good sleep as you possibly can. First, I want to talk about normal sleep. Sleep latency is a term to describe the amount of time it takes to fall asleep after the lights are turned off. Normal is about 10 to 20 minutes. So it shouldn't take you, for example, an hour to fall asleep once you've turned off the lights and decided you're going to bed. There are different stages to sleep: REM sleep, rapid eye movement, and non-REM. These will cycle throughout the night, alternating with more REM in the second half of the night. And the normal sleep length is about 7 to 9 hours per night. Keep in mind that everyone is different. One person may need 7 hours and another may need 9. So if you have a couple who's 7 and 9, you may need different hours of sleep per night. Now, sleep in Parkinson's is a very common, what we call non-motor symptom. So we all know about motor symptoms in Parkinson's: the tremor, slowness, stiffness, gait problems. There's also non-motor symptoms: constipation, cognitive, mood issues, etc. Sleep is another one of those non-motor symptoms. Most of patients with Parkinson's will have at least one sleep complaint. This can be insomnia, excessive daytime sleepiness, restless leg syndrome, or behavioral sleep disturbance. And actually, there's evidence coming out that sleep alteration might even be an early sign of Parkinson's. And this is because the biology of Parkinson's affects the brain in such a way that sleep is also affected and wakefulness is affected. This is a diagram I made based on sleep disturbance in Parkinson's. You can see it's very complex. There's a lot of things that may contribute. And today we're going to go through all of these circles here. So it includes excessive daytime somnolence, sleep apnea, restless leg syndrome, insomnia, poor sleep hygiene, and REM sleep behavior disorder. First, I want to go through insomnia. Insomnia is very common. You can see the cartoon here. Insomnia is very common. Try not to lose any sleep over it. It's estimated to be up to 3/4 of patients with Parkinson's can have this. And in the general population, I'm sure you know people who also have insomnia. This is defined as difficulty falling or staying asleep that results in daytime impairment. The most common issue is usually staying asleep, which is called sleep maintenance. There can be multiple potential causes. It could be a motor off symptom, a urination or urological issue, anxiety, medication side effect, sleep apnea, restless leg, REM sleep behavior disorder, or poor sleep hygiene. There's a lot of different possible contributions. The treatment number one is you're going to look for a reversible or treatable cause. So if it's a motor off state, your tremor waking you up, or dystonia pain, you can treat that with Parkinson medicine. Keep in mind too, there could be other things that affect it, like pain from non-Parkinson's causes as well. So you want to make sure that gets treated. Anxiety or depression can also cause insomnia. So if you have untreated mood issues, you want to get those addressed. Medication side effects are common with Parkinson medicines. In particular, amantadine and selegiline, if you take it too late in the day, can cause insomnia. And the dopamine drugs, like dopamine agonists and levodopa, can cause sedation or insomnia in some cases. Nighttime urination is a common reason why people wake up. Many people have to wake up at least once per night, but if it's 3, 4, 5 times per night or more, you can see how that might interrupt your sleep, and that can be addressed separately, either by seeing a urologist or if it's related to the Parkinson's with potentially Parkinson medication. Sleep apnea, restless leg syndrome, REM sleep behavior disorder, and sleep hygiene issues can also be treatable, and we'll talk about those a little bit later. There's actually limited drug treatments. There's a lot of medicines that are out in the market, but they're not necessarily safe for Parkinson's, so there's not a lot of oral pills you can take to get you to sleep throughout the night. One option is also to adjust your schedule. There's no rule you have to sleep 8 hours in a row. If your body only wants to sleep 4 or 5 hours at a time, and then you're awake enough to do some activity and then go back to sleep, you can also split your time if necessary, rather than trying to medicate yourself. That's if your schedule allows that. And then cognitive behavioral therapy can be quite helpful. Cognitive behavioral therapy for insomnia, or CBTI, is a structured program that helps you identify behaviors that are affecting your sleep, and you replace them with healthier sleeping habits. This helps you overcome the underlying sleep problem, especially important if you've had chronic long-term insomnia. How to do this? You want to get the help of a cognitive behavioral therapist that's trained in this. There's also apps available if you're interested. CBTI, Coach, and Calm I listed there. Next, I want to discuss restless leg syndrome. Restless leg syndrome is very common. It's common in the general population. I'm sure we all know people who have it with or without Parkinson's disease, but it has an increased prevalence in Parkinson's. More common with the duration of the disease, how long you have it, and it's most likely due to a medication effect. You can get something called augmentation with dopamine medicines, where too much dopamine actually makes the restless leg syndrome worse. The criteria for restless leg is that 1, you have an urge to move your legs. That's worsened by rest, improves with activity, and is worse in the evening. So often people will say that they start feeling these symptoms when they sit down and watch TV in the evening or go to bed, or go to lay down in bed, and they have to get up and walk around. So how to treat this? Number 1, you want to make sure you have restless leg syndrome. Do you meet those criteria I just mentioned? The urge to move your legs, the improvement with activity, worsening with rest. Sometimes you can have restless legs during the daytime too, but you want to make sure that diagnosis is correct. So you want to rule out any mimickers, joint or muscle pain, cramps, a circulation, a vascular blood flow issue. Look for triggers. If you recently restarted on a medicine, especially antidepressants, they can worsen restless leg. So you can talk about alternatives if that's the associated risk factor. You do want to look for low iron. Low iron can be associated with restless leg as well, and usually treat this if it is low, keeping in mind that iron can often cause constipation too, which is a problem in Parkinson's. You can try to reduce dopamine medicine, but this is often not possible with Parkinson's patients. So a good option is to consider gabapentin or Lyrica at a low dose and can be fairly effective in most people. Next, I want to discuss excessive daytime somnolence. So what is it? First of all, it's not fatigue. Fatigue means you're drained, exhausted. Somnolence is sleepiness. So this is someone who is falling asleep throughout the day, watching TV, reading a book, in the car, just easily falling asleep. And this is if it's excessive. Many of us can fall asleep, in one setting or another, but if it's excessive, daytime somnolence, that's what we're talking about. This is very common. It could be in up to a third of patients. It could even be an early symptom of Parkinson's. Although the literature does support that usually in early disease it's due to medication. Some of the dopamine medicines can cause sedation, especially dopamine agonists can cause sleep attacks. But it does tend to increase as the disease advances. Also in males, and more medicine you use, you're more likely to have it. You treat this, number one, by treating any treatable causes. So sleep apnea is a common cause of excessive daytime somnolence. Sleep apnea I'll discuss a little bit later, but if you do end up having that, you want to make sure that gets treated. You also want to reduce any medicines that might be contributing. So dopamine medications, if you can reduce them, or any other medicines that might be making you sleepy. There are unfortunately limited other medication options. Caffeine you can try. Stimulants could be helpful, but you have to be very careful about the cardiovascular side effects. And there is some research on light therapy as well that might be helpful. Next, I'm going to talk about REM sleep behavior disorder. REM sleep behavior disorder, RBD, is approximately found in half of patients with Parkinson's. It's one of the most specific symptoms of Parkinson's. This is thought to be a prodromal symptom of Parkinson's. Before you're even diagnosed, you can have this. What happens is during REM sleep, your muscles should be paralyzed. You shouldn't be moving. Because of the pathology in the brain no longer can paralyze you while you're dreaming. And so people end up acting out their dreams. And this can actually be very vivid, even life-threatening dreams. People will dream that they're being chased or fighting someone or something, an animal, even jumping out of bed. And this can lead to injury for the patient or even the bed partner. And it may be under-recognized in women because some of the dreams might be less aggressive and might not be as many injuries. The treatment of this is surrounded by safety. So number one, you want to prevent any injuries during sleep. You should look at your bedroom safety. The area right around the bed, make sure there's no firearms or large objects that might be used during a dream. The height of the bed should be lowered if possible, so if you do jump out of bed, you won't hurt yourself. Many people end up sleeping separately from their bed partner. And a bed rail also can be helpful to keep you in. In terms of medications, there's a couple of options. Number one, first line is melatonin. This is over the counter, it's generally pretty safe. But the primary purpose is for dream enactment, so you want to keep that in mind. It's not for insomnia. It's not usually that effective for insomnia, although you can try it, but it's really you're looking at it to help the dream enactment. Clonazepam at a low dose can also be helpful. Keeping in mind that this is a benzodiazepine. It is a controlled substance, and there's potential side effects with it as well. So if the dreams are affecting your safety, it's reasonable to consider it, understanding the potential side effects. Other non-invasive options, you can try a bed alarm. You can have a familiar voice record some reassurance. The patient does try to get out of bed. And this can also be exacerbated by certain medications. So keep in mind certain antidepressants, even memory pills, can worsen this behavior. Next, I'm going to discuss sleep apnea. So obstructive sleep apnea, or OSA, is very common. I'm sure most of us know somebody who has sleep apnea. It's not necessarily more common in Parkinson's, but the people that do have it tend to be thinner. It's not usually a weight thing in Parkinson's necessarily. What happens is when you have sleep apnea, you're not breathing effectively during night, and your body basically wakes you up, and it can be many times throughout the night. So even though you think you are sleeping, it is not necessarily good quality sleep. So how do we know if you have this? Well, the screen for it usually is looking for daytime somnolence, which I already mentioned could be just one of the symptoms in Parkinson's. So there's a questionnaire called an Epworth Sleepiness Scale that we usually use. And it has questions like, how likely are you to fall asleep while watching TV, reading a book, etc.? If you score really high on that, or in the abnormal range, you could consider a sleep study, but it's not necessarily routine. But if you do have a witness apnea, that means someone has seen you stop breathing while you were sleeping, or if you have a stroke history, because sleep apnea tends to be more common with strokes, and you want to find out if you have it, you're willing to undergo the test and the treatment, you should consider a sleep study if you have a lot of sleepiness during the day. The sleep study is usually done at home or in a sleep lab. The treatment, most of the time, is positive airway pressure, a CPAP, BiPAP. And keep in mind that many people do have trouble tolerating it. So if you do have trouble or have had in the past, you want to make sure that you're working with a sleep specialist to look at other options if you're a candidate for that. And next, I'm going to talk about poor sleep hygiene. Sleep hygiene is the behaviors that we do to improve our sleep practices and make our sleep better. So number one is to go to bed the same time and wake up the same time every day. It's hard to do if you have a different weekday, weekend schedule, but it is important for your sleep hygiene that you're staying on a regular schedule. If you do decide to take a nap, you want to make it short and usually before 3 p.m. If you take a really long nap in the afternoon, it might be difficult to fall asleep at night, as you can imagine. Now remember, the typical sleep duration is about 7 to 9 hours. So you want to make sure that you're budgeting that amount of time for your sleep. And daylight sun exposure is actually very important. So you want to make sure you are getting some exposure to your eyes in the daytime. That actually helps make natural melatonin. Some other sleep hygiene tips. You can try satin sheets to help you move better in bed if you have some trouble turning over. Make sure your bed is conducive to sleep. So it should be a calm, quiet environment. The temperature should be just right for you, not too cold, not too hot. You want to avoid electronics, and this is really tough, but any laptop, computer, cell phone, smartphone, anything with a screen, iPad, you want to avoid that if you can, about 1 to 2 hours before bed, because that can affect your sleep quality. And most important is if you can't sleep, the recommendation is you don't stay in bed too long, longer than usually 15 or 20 minutes. It doesn't mean you set a timer, but usually people can, look at a clock and tell that they've been in bed for, example, an hour, and they're just not sleepy. So if that happens to, the recommendation is actually get out of bed and do something boring. You want to be careful what you do or you consider boring. You can see the cartoon here. You don't want to read anything that's too stimulating, because that can actually keep you more awake. You want to avoid any other stimulation right before bed as well. So caffeine, nicotine, alcohol, food, and vigorous exercise. A special note on sleep and exercise. So there's a recent study of persons with Parkinson's. It's 2 groups, about less than 30 in each group. They were not in a regular exercise program. So they randomized them to an exercise group and a control group. The exercise group were enlisted in a supervised exercise program 3 times a week for 16 weeks. And I do want to note that the exercise was prior to 2 p.m., so they weren't doing it too late in the day. The other group got in-person discussions and monthly phone calls on sleep hygiene. The results were that they found the exercise group did show improvement in sleep efficiency and other sleep parameters. And the conclusion was that high-intensity exercise may help sleep too. So if you're not exercising with Parkinson's, another reason to start exercising is it may help your sleep if you're having trouble with that. So in summary, I'm going to go over the things that I discussed briefly. So with Parkinson's, a sleep disturbance is intrinsic to Parkinson's. I talked about the pathology, biology that affects our brain in such a way that you may have trouble with sleep. REM sleep behavior disorder is most specific for Parkinson's, acting out of the dreams. And excessive daytime somnolence can happen because of the pathology in the brain. Although not necessarily specific, it can also be seen in sleep apnea. Poor sleep hygiene, sleep apnea, insomnia, and restless leg syndrome are common in the general population. Many of these can be treated or improved upon depending on what is bothering you the most. You just have to figure out where you can see some improvement. And as usual with Parkinson's, exercise helps. I'd like to thank my colleagues for giving me some feedback on this talk and to PANC for organizing this. And with the last few minutes, I'd like to go over some questions that you submitted in your registration. So there's some questions about insomnia. What is the best sleep aid for Parkinson's? So there are not that many that are considered to be safe. Number one is usually melatonin because it's over the counter and has very few side effects. But like I said earlier, it doesn't necessarily help you stay asleep. It might help you fall asleep if that's your problem. Other options would be at low doses, doxepin or trazodone, usually are well tolerated. Keeping in mind everyone is different in how they tolerate it. So some people may have side effects, but those are usually felt to be safer in Parkinson's than, for example, Ambien. And then mirtazapine, Remeron, is also an antidepressant. So if you're having trouble with anxiety, depression, it can help fall asleep as well. So those are usually the medications that are go-tos for me. What about CBD or THC for sleep? So marijuana is a big topic. There's a lot of hype about it. THC I usually never recommend because of the side effects. CBD, however, I'm not opposed to trying that. I don't know if there's enough evidence to formally recommend it, but you have to be careful that you're getting it from a trustful source and that you are still watching for side effects, because I have seen some patients still have side effects from that. Why is Benadryl not good for sleep in Parkinson's? That's a good question, because many people know about Benadryl. Diphenhydramine is the other name for it. It's in Tylenol PM, Advil PM. It's very commonly used as an over-the-counter sleep aid. Even though it's over-the-counter, it doesn't mean it's safe for you in Parkinson's. The reason is it's in the class of medications called anticholinergic. Acetylcholine is a neurotransmitter in the brain that's very important for your cognition, and this goes against that. And so if you take Benadryl, it can affect your cognition, memory, thinking. It can also lead to or worsen constipation, dry mouth. So it's just something to keep in mind, that you want to make sure you tell your doctor about all your medications that you're taking, even over the counter. A question about sleep apnea. Does CPAP help with sleep disorders in Parkinson's patients? And the answer is yes. If you have sleep apnea, you definitely want to get this addressed and treated if you can. I understand that many people have difficulty tolerating the CPAP or BiPAP, but you can always talk to a sleep specialist about other options, or see if there's any way that you can adjust it so that you would tolerate it. But I think it is important to get it treated if you do have sleep apnea. And then in general, a question about sleep. Is it possible to get 8 hours of straight sleep per night with Parkinson's? And that's a tough one. So sleep is, as we talked about, very important. And even if you don't have Parkinson's, it might be difficult to get 8 straight hours of sleep. Many people have to get up to use the bathroom or have other things that they're thinking about. But I think you can definitely get better quality sleep if you work on it. But it can be a very difficult thing if you're shooting for 8 hours straight. Medications often won't do that. You could get lucky if one of those do help, but it's really tough. So I'm not sure that's possible in everyone. If you do sleep well, you're very lucky, and cherish that time, because it's hard for many people. Those are all the questions that I had, and thank you guys so much for your attention, and hope you enjoy the rest of the conference.
Thank you, Dr. Bird. The information that you shared has such practical purposes for persons with Parkinson's disease and for anyone. My name is Mary Beth Argel, a young onset person diagnosed with Parkinson's disease at age 43. It is now my honor to invite Dr. Suketu Kandar back to the stage and to introduce our keynote speaker. Dr. Sonia Mather, joining us remotely, is a family medicine physician outside of Toronto, Canada. She resigned from her practice 12 years ago after her diagnosis of young onset Parkinson's disease. She is now a dedicated speaker, writer, educator, and patient advocate. She works with the Michael J. Fox Foundation for Parkinson's Research on their Executive Scientific Advisory Board and the co-chair of their Patient Council. She serves on the boards of the Davis Finney Foundation, the Brian Grant Foundation, and the Medical Advisory Board for the Parkinson's Canada. Dr. Mather has a special interest in helping educate the youngest affected by the stress of this chronic disease. To help facilitate dialogue between children and their loved ones, she has authored 2 books, My Grandpa's Shaky Hands and Shaky Hands, A Kid's Guide to Parkinson's Disease. Please enjoy the discussion between Dr. Kandar and Dr. Mather.
Thank you so much, Mary Beth, for the lovely introduction. And thank you, Dr. Mather, for actually joining us here today, Zooming all the way from Toronto.
My pleasure.
So nice to see you. I think the last time I saw you, Sonia, was back in Kyoto when we were at the World Parkinson Congress last year.
Yeah, that was quite the conference. It's great.
So today we have quite a few questions that we're going to be asking of you as someone living with young onset Parkinson's. We here at the Parkinson Association felt that it'd be best to ask our young onset support group to give us questions that we then of course could ask you. So it's basically by the audience for the audience. So without further ado, let's begin. When did you share this diagnosis with your family or your workplace? And how did it affect your work and what went into the decision of stopping work? So maybe we'll start with the question about how did you share this diagnosis with your family and workplace?
Yeah, the question of disclosure is an interesting one, isn't it? It's something that's really individual for everyone. For me, I started off telling my closest family. A couple of sister-in-laws and my husband were the first to find out about my diagnosis just because I needed the support. But it took me about a decade before I actually disclosed to my wider social circle and friends, extended social circle. And that for me was for a couple of reasons. One, it was because I hadn't really come to a point of emotional acceptance for my diagnosis. It was really hard for me to accept that at age 28, I was diagnosed with a progressive neurodegenerative illness. And I also didn't want to be perceived in the workplace as being less capable, because unfortunately, there was at that time and still is a bit of social stigma attached with the diagnosis like Parkinson's, when it really should not be, of course. And I felt that my patients wouldn't sort of trust my opinions or my work as much as they had in the past. So for those reasons, I kind of held off for a while, but it got to the point where I couldn't hide my symptoms anymore. And it was expending so much more energy, trying to hide them rather than just come clean, I guess, so to speak, and discuss my illness with other people. So it took me a while. I got there.
For the audience members that are not aware, at the time you were basically finishing and completing your residency as a medical doctor. And so with those long days, those long weeks, how were you able to basically navigate without having told anyone at the workplace that you had Parkinson's?
Yeah, well, I actually was diagnosed just as I finished my residency in family practice, and I was expecting my first child, so it wasn't the most convenient time to get a diagnosis. But the first few years of medical practice, as you can well understand, are busy times. So I was starting a new medical practice. I had the first of my 3 daughters. Building a new house, those sorts of things really sort of kept me busy. And it got to the point where I wasn't balancing it very well. As you know, also medicine kind of consumes your life. There's no really part-time medical practice. You just kind of put all that work into fewer hours if you try and go part-time. And being a mother was and is my passion. And I didn't want to give that less than 110% either. So what suffered was my health, and my self-care was non-existent. So it got to the point where one of the movement disorder specialists I was seeing at the time basically said to me, do you want to walk out of your office at the end of the day, or do you want to crawl out? It's up to you, but you can't continue on this path of trying to do everything and neglecting your health in the process. So that's what kind of led me to stop working at about, I think I was 12 or 13 years into my diagnosis at the time I stopped clinical practice.
So that's actually kind of leads me into the next question, is that how did you balance having Parkinson's, working, and having a family at the same time? And you, after the time of diagnosis, you still worked for another decade and a few years.
Yeah. How did I do it? I didn't do it very well. That's because as I mentioned, it's just so hard for me to find the time for self-care, which is really, really vital when it comes to managing Parkinson's disease. I was burning the candle at both ends, trying to fit everything in and trying to be the best doctor I could, the best mother I could, the best wife I could be, and really neglected myself in the process. So it wasn't very easy to do. I struggled with that balance, like I'm sure a lot of other people do. And prioritizing yourself is what I tell people that they have to do, that's paramount, that's vital in order to live well with this disease. So that balance has to be there. I just wasn't very good at it.
Which one Parkinson's symptoms bothers you the most, and what helps you deal with it?
That's a great question. As we know, there are motor symptoms of Parkinson's disease and non-motor symptoms. And the non-motor symptoms, if you poll people in the community, seem to be the most bothersome when it comes to affecting your quality of life. For me, my quality of life is most affected by the off periods that I experience, which can be unpredictable and sporadic. They can last a few minutes, or they might last an hour or two. And that's basically when my medications stop working. So I get very stiff, I get very tremulous, I get anxiety also when that happens. So those off periods, I think, are the worst for me. And what I found is very helpful is routine. So making sure I take my medications regularly and on time, making sure that I exercise regularly, because I find if I don't exercise, my off periods are worse. If I don't sleep well, my off periods are worse. So sort of looking at those variables that I do have control over, such as my medications and lifestyle issues, that if I optimize them, really do help control those off periods.
Yeah, that's actually probably a good segue into the next question. You sort of being right there on the sidelines when it comes to what's new and innovative with Parkinson's, given that you are on the board of directors for the Davis Phinney Foundation, you also work with the Brian Grant Foundation, certainly with the Michael J. Fox Foundation, and also with the World Parkinson Congress. What new medications or treatments excite you the most as being the most promising for those living with PD?
Yeah, that's a really great question, and one I get asked a lot. And what I would say actually is, it's not so much the medication as the direction of research that I'm most excited about. When I first started in this sort of community, maybe over 20 years ago now, the talk was all about dopamine. It was all about replacing dopamine, how to get the dopamine to where it needs to be in order to relieve symptoms. Now the research landscape is so much more. We're not just talking about dopamine anymore. We're looking at Parkinson's as a whole body disease, not just a motor illness, but so much more. And so our understanding of the disease is increasing, and that's what excites me most, because you really can't cure what you don't know, right?
Very true.
Sorry?
No, it's very true.
Yeah, so I think that increased understanding of the disease is what excites me the most, the out of the box thinking. So we're not just sort of have our blinders on and saying, this is all about dopamine. This is what we have to do. So that out of the box thinking, looking at Parkinson's disease as a whole body disease and how it affects patients in terms of their quality of life, and also searching for that biomarker. That's also very exciting research to me. A biomarker, as you know, is an objective marker of this disease. It's like your glucometer checks for diabetes or your blood pressure checks for hypertension. That allows your physician to manage your disease based on an objective reading, as opposed to just what they see when you're in the office, which is just a point, of evaluation. Doesn't really reflect how you are in your own environment. And also is a very subjective thing in terms of you relaying your symptoms to your physician. So looking for an objective marker, I really am excited about, and I think that's what's going to really move us forward in terms of not just clinical management, where your doctor has something substantial that they can look at, but also in terms of research, right? If we know that a drug lowers some sort of marker in our blood, say, that can really propel us in the right direction when it comes to research. So there's, drugs that are coming down the pipeline that are either disease modifying or treating symptoms that are exciting, but it's really the direction and our view of Parkinson's disease and the cause of it and how to measure the disease, the fundamentals of, I guess, Parkinson's disease that excites me the most.
Now that we're on the topic of treatment, and I kind of going to group two questions here together. With someone living with young onset, would you advocate to starting levodopa early? And on top of that, would you advocate for considering deep brain stimulation early?
Those are great questions. Whenever I look at changing a treatment, either in myself or if I'm looking at other people in my community, the one sort of thing I hold true to is quality of life, because until there's a cure, it's all about quality of life and maximizing your quality of life. So any treatment changes I make, as I said, on my own, or that I see for friends of mine or other people in the patient community, I always ask that question: how's your quality of life? If your quality of life is good, then just leave it as it is. So if you're started on a medication that isn't levocarbidopa, and you're fine with that, great. But if you get to the point where your symptoms are impinging on what your life experience should be, that's the time to make a change. And levocarbidopa, I think, that's the gold standard that we compare other medications to. It's been that way for well over 50 years, and unfortunately, we have the same gold standard drug that we did back then. But it works really well to control symptoms. There was a time that we thought that starting your medication or dopamine replacement might progress the disease faster, because they found that people were having to take more and more of it in order to control their symptoms. But we now know that that's really not the case, that your disease is worsening as because it is a progressive illness, and that you're having to take more medication just to manage increasing symptoms. So because of that, I don't think there's any reason to hold off anymore when it comes to a dopamine replacement.
Now, what about deep brain stimulation?
Deep brain stimulation, I can, it's about quality of life. I mean, they've been asking me to do deep brain stimulation for quite a while, but I keep holding off because I feel my quality of life is really good on what I'm treating myself with now. But deep brain stimulation in the younger population has been supported by a couple of studies. One came out, I think, in 2014, the early STIM PD study, where they looked at patients that were getting deep brain stimulation early in their course of disease versus just staying on medication. And they found that there was less motor complications, better quality of life, and need for medication was less in the group that went for early DBS, as opposed to waiting and just being on medication. Right. And I think there was another study, a pilot study that just came out this summer, which showed pretty similar effects, that it seemed that the people that received DBS early were, again, less likely to have motor complications and less likely to need a lot of medications to control their symptoms compared to other people. And they're going to be doing a larger study to examine that further. But I guess my answer would be, so science seems to be starting to support that potentially may be helpful. And if the scientific studies come up showing that it actually does help slow the progression of the illness, then my answer might be different. But at this point in time, it's basically for you to look at your quality of life and judge whether or not you need to add different medications or you need to go the DBS route. It's not a simple decision. It's really more of an individual one.
And I appreciate you being candid about your own thoughts about DBS for yourself. That said, I actually wanted to ask another question about exercise. So this comes directly from, again, that young onset support group. I've noticed that the exercise programs for Parkinson's are available in my area and are geared towards the population most affected by Parkinson's, who are mostly retired, so they are scheduled during my work hours, not quite at the intensity level that is recommended for me. Have you experienced this challenge, and how do you address it?
Yes, exercise. That's everyone's favorite topic. Some love it, some don't like it so much, but exercise is really the most important thing that you can do as an individual with Parkinson's disease. If you want to optimize your symptoms and optimize your life experience, really, exercise is that important. For myself, I agree. I think that it's difficult to navigate some of the exercise classes because the vast majority of people are not young onset patients. The vast majority are older sort of comrades, I guess, in the community. And so a lot of exercise classes are geared to that age group. The important thing that I found for myself was that, and you have to look at yourself and be honest about it. I mean, I like to exercise, I exercise, but I don't love to exercise. It's not like, some people crave to go out for a run. That's not me. So you have to find something that you're interested in and that you can do on a daily basis, something that you can maintain, because there's no point in starting a class if you're not going to maintain it. It's the consistency that's most important. So for me, I find that I can't really go out of the house. If I have to actually get in the car and drive somewhere to go, I'm not going to do it. So you kind of find your own limitations. Accountability is really important for me. It's what drives me if I have to face somebody else and say I did or did not exercise. So what I had was I had a personal trainer come to the house initially so that they would sort of motivate me to keep going with a regular exercise routine. And now I've sort of graduated to the point where I work it into my daily schedule. It's first thing in the morning because I won't do it later on. And I exercise at home. I do Pilates, yoga, weights and walk the dog and bike and things like that that I enjoy and that I will do consistently.
So to kind of expand on that, do you ever involve your family in your exercise routine? And if you do it at home, are you using things like Zoom, particularly during this pandemic?
I think it's a great question. I do involve my family to some extent, but I like to exercise at 5:30 in the morning just because that's quiet. And
That's early.
no one really wants to get up with me at 5:30 in the morning. But I mean, we do as a family go on hikes and bike rides and things like that, which are enjoyable when the weather's good, which is not the whole year up here in Canada as opposed to where you are. So I do involve my family to a certain extent. Zoom is a great way to connect, particularly during this pandemic. I think that the lack of ability for people to travel to do their exercise classes or their physio or their massage therapy, things like that, have really taken its toll on people with Parkinson's disease, not to mention the social isolation. I mean, the socialization of these exercise classes is probably almost as important as the exercise itself, that feeling of group and belonging and the emotional support that comes with being in a group of like-minded people. So Zoom is excellent, an excellent way. And there are so many resources, so many excellent facilities that are giving classes or access to classes for Parkinson's. And unfortunately, we don't know how long this is going to last, this kind of isolation or restrictions in terms of activities. So I think it's important to maybe, try a few out and see what suits you in terms of time and effort and go for it.
That's kind of sort of what I tell my patients as well. And, not everyone has the capacity to be able to have a personal trainer come to the house or be able to, sort of exercise in a wide array of different exercise programs. But what's important is that individual actually do what they find most interesting, what they know they're going to be compliant with, and what actually suits their personality.
Absolutely. And it can be dancing, it can be Tai Chi, it can be yoga, it can be kettlebell, Pilates. Walking is a great way to get exercise, whatever was within your capacity to do and maintain. I think the regularity of it is what's most important.
Fair enough. So I have another question, maybe a little bit difficult to answer. Many people have a difficult time asking for help. What suggestions do you have for someone that knows they need help, but isn't the type who feels comfortable asking?
This is going to be an answer that I know is the right thing to say, but not that I follow it myself, because I'm terrible at asking for help. And I'll tell you why. It's not that I feel that asking for help is a weakness, because it's not. It's actually a smart thing to do, to try and navigate what you need to get done by using the resources that you have around you. And that means having people help you. So I know it's not a weakness, it's actually a strength. But for myself, I always feel like I'm sort of losing a little bit to the disease if I ask for help. And that's just something I have to work on internally. I mean, we're all, as this disease progresses, so does our need for introspection. And that's something I have to work on. But I would say I've definitely noticed from a care partner or family or friend's perspective that there's a sense of helplessness on their part. They can't do anything to stop the progression of this disease. They can't cure you. So when you allow them to help in a certain way, that's a feeling of empowerment for them as well. You're giving them an opportunity to do something for you, and that actually makes them feel good about it. So I'm trying to look at it from that perspective as well, that not only are you getting the help you need, but you're actually helping them in a way by allowing them to do something concrete, which will give them that sort of feeling of empowerment to some extent.
Kind of along that line, you wrote 2 children's books on Parkinson's disease, one really geared towards the toddler population and one really geared towards the family. And many of you in the audience actually got that book as part of your registration, so I hope you've enjoyed it. What inspired you to write a children's book? And I'm assuming that you obviously got a lot of your family support in writing it and their family's help in writing it as well.
Yes, it was my children. I mean, I'm a big fan of children's books. I collected a bunch when my girls were growing up. Reading was a very integral part of our day, before bed and so forth. We did a lot of reading as a family. And I was always fascinated by, the process of writing and that sort of thing. So that's what kind of led to the first one. My father also had Parkinson's disease. So the first book was My Grandpa's Shaky Hands. That was kind of inspired by him and the fact that I saw my children really not notice anything was wrong with him in terms of his symptoms. That's not what they noticed. They noticed the good things about him, the things that they loved most about being with their grandfather. And the second book came when my children were a little bit older and were sort of getting to understand what Parkinson's disease was all about, and were asking more questions about, the fundamentals of Parkinson's. Why did it happen? What can you do to help? What can they do to help? And so forth. So the second book, which is the one I think that the audience has received,
Right.
Was geared to their age group. So at that time, I think they were 6, 10, and 12, or around that, or maybe 8, 12, and 14. It's not really age specific, but it's geared for a little bit older in terms of children. And that was, we all wrote it together. My daughters and I wrote it together, and I'd run, ideas past them, and they were involved with parts of the writing of the book as well. And that was really cathartic. It was really a great project to do. But it stemmed from my observation that, particularly with my daughters, they fear the unknown. They're worried about things that they don't understand. So I think that being very open and honest with your kids and having that discussion is really important in terms of how they handle it, because really it affects the whole family. Our diagnosis isn't just for ourselves, it affects our whole family unit, particularly the children. So having that open dialogue and being able to explain things for their level of understanding, I think is really important. And that's what kind of inspired me to write the second book.
Well, I think that a lot of people are going to find that book inspirational and maybe use it as an opportunity to be able to share that diagnosis with their families.
Yeah, I hope so.
Since being diagnosed with Parkinson's, I've tried to be more informed about Parkinson's by connecting with different organizations, signing up for workshops, conferences, webinars, connecting with support groups, and joining exercise programs for Parkinson's. I'm learning a lot and I've met wonderful people in the Parkinson community. However, I also feel like I have been living in a Parkinson bubble. Do you have tips on how to live a more balanced life, focused not just on dealing with Parkinson's, but all of life?
That's a really interesting question. I think and I understand where that's coming from. I'll often say to my husband, I'm kind of PD'd out because this disease is ever present. It doesn't sort of take any time off. So it's always sort of affecting you and in the back of your mind. What I say to people and what I say to myself is that this disease doesn't define me. This diagnosis doesn't define me. If I were to ask my family, my friends, to write down, say, an adjective or a descriptor of what they would think would be suitable for me, it's not going to be Parkinson's patient. It's not going to be sick or ill or, disabled. It's going to be things like, hopefully a good person or a great friend or a valuable colleague or, a fun mother. These are the descriptors. These are the roles that we play. These are the roles that are much more important in defining who we are other than Parkinson's disease. So I keep reminding myself of that I'm much more than this disease. I'm a lot of other roles in my life. And I think that that's really important, to have that kind of introspection, inner dialogue with yourself, and remind yourself, this is just part of you. This doesn't have to be you. You're defined in so many more valuable ways than just your disease.
I really appreciate that, because I think a lot of our audience needs to hear that, particularly from someone like you who's already lived it, to know that it doesn't have to define you, that maybe it can just sort of remain your shadow, because it will be with you, but you can redefine yourself, or you can define yourself however you'd like to define yourself, and hopefully in a very positive way. How can Parkinson patients get more actively involved in research? I know that this has also been sort of something you've helped to promote over the last several years.
Yeah, participating in research is really, really a passion of mine. When I used to talk, when we were able to travel and talk to people in person, one of the questions I used to get, or usually get, is, so what's coming down? What are they working on? And I would say, well, they're working on such and such. But I began to realize that they aren't working. We as a community have to be responsible for the work that's being done. I mean, part of the problem is with clinical trials is that they're delayed. 80% of clinical trials are delayed because of recruitment issues. And up to 30% can end up not even recruiting a single person, which is a huge waste of time and resources. So clinical trial participation is really, really important. And that's something that we as a community need to understand, that we are part of the search for better treatments. We are part of the search for a cure. And without us, it can't proceed. Knowing that, I do know that there are a lot of myths and misconceptions out in the community about Parkinson's disease research or research in general. And I think that as patients, we need to educate ourselves on what being involved with research is all about. I mean, there are so many ways to become involved. It doesn't mean that you have necessarily, brain surgery as part of a research trial, though there are trials that are geared towards that. But there are simple things like, surveys online or one visit to do some blood work or to take a test or that sort of thing. Whatever is geared to your situation, your location, your time limits, your lifestyle, there's something that can fit you in terms of clinical trial involvement. And it's so very important. I would start off with asking your neurologist or movement disorder specialist that you see in their center what types of research they have going on that you might be involved with. And there are things online. There's clinicaltrials.gov, I guess, in the US that you could access for Parkinson's trials. There's Michael J. Fox Foundation's Fox Trial Finder, which is like a match.com service where they, depending on geographical location, will match you with trials that are taking place worldwide. So there's ways to get involved, but it's really important for you to consider supporting our research community so they can do the work that will ultimately benefit ourselves.
I agree, and it's not just about research that helps others, it's also self-empowerment too. I think that of my patients who have actually involved themselves in research, they feel like they're one step ahead of the game. They feel like they're contributing to something grander than just the care for themselves, but ultimately, like you said, it really will impact them as well and their family members. I also find that there's a certain personality that starts to develop in someone who actually is participating in research. They start being a little bit more routine with their medications, they start actually being more active in their exercise program, start being more connected to the community. And they're more than willing to share their experience with others who may actually be on the fence about whether they want to or not.
Right. I mean, I think that's where we can learn the most is from people that are already participating as patients that can sort of be the ambassadors for clinical trials in general. Absolutely.
Well, thank you. And everybody in the audience, please consider being part of research programs, even if it gets you to the PANC website, ask somebody, ask your local movement disorder neurologist, or even our academic centers locally here. So in the last minute that we have here, I want to ask the question I saved the best for last. What is the best part of having Parkinson's?
The best part of having Parkinson's. I'm hesitating only to sort of gather my thoughts because there's really a lot that I have learned about myself through this process. And all of those things have been, it's been much more of a blessing than a curse. I will say that. It's taught me to prioritize things, reprioritize what's really important in my life. That's something that I've really benefited from. It allowed me time to do so. Because although it sort of took my career away from me early on in terms of clinical work, it certainly allowed me to be there more for my children at a time that they needed me when they were growing up. And it certainly allowed me to pursue this role of advocacy in patient education and clinical trial enrollment. And it's things that I'm really passionate about. I feel like I found my life's passion in the work that I do. And it's been, as I said, more of a blessing than a curse. It's taught me that, we're going to face challenges in our life when it comes to not just this diagnosis, but many things. And it's really something we don't have necessarily control over, but how we react to those challenges, how we face those challenges that come up in our life really define the people that we are. And so I think that sort of development of me as a person and the lessons that I've learned from dealing with this challenge for now well over 22 years has really been the best thing for me. And I've always felt that this is sort of the trajectory my life was supposed to take, I wouldn't really change it for, I mean, obviously it'd be nice not to have Parkinson's, but I've never been a why me sort of person. It's why not me? I can learn from this experience, and I've learned a lot.
Thank you so much, Sonia, for your insights. Your life's been an inspiration, and I really appreciate you sharing this time with us here for our audience to appreciate what you've been through. So thank you so much. And I think that concludes our fireside chat.
Thank you, Dr. Kondar and Dr. Mather. We really appreciate your enlightening session. Hi, I'm Christine Shade. I'm the Vice President for the Parkinson's Association of Northern California, and I'm here to introduce our short movement break leader, Kathy Van Hoof, who is an instructor for Dance for Parkinson's. She's been teaching with the Sacramento Dance for Parkinson's program since 2012, and she was a member of the Ruth Rosenberg Dance Ensemble, performed with Sacramento Ballet, and has her bachelor's degree in dance from Sacramento State. Enjoy.
Thank you, Christine, and welcome to you. I am here as part of the Sacramento and Davis Dance for Parkinson's program. Dance for Parkinson's is actually an international organization offering dance class to people with Parkinson's exclusively worldwide. We know from a forum such as this conference just how important it is to have a movement program or 2 or 3 in your life. The thing about the dance classes in the Dance for Parkinson's program is it's a unique combination of movement, dance, music, community that engages the body, the mind, the heart, and the soul. And we have fun at it. So today, we're going to do 3 short movement exercises to music. The first thing we're going to do seated. So let's find ourselves a chair, if you don't already have one, that you can sit comfortably in, but you need to be in such a position that you can move your arms out to the side, up. Legs will actually end up going out too. So here's the thing. No right or wrong here, no right or left. It's just what's right for you. And the idea here is to get the blood flowing, a little energy coursing through the veins, but also to give you an idea what we do in the Dance for Parkinson's class. To begin with, we're going to start out a little bit slow, take it easy, get some of the kinks out, and you're just going to follow along. That's all you got to do, is just follow along. Music, please. Now, take a deep breath and let it out. Again, breathing in and out. Comfortable in your chair? Seated up? Now just drop your chin and lift it to the ceiling and front. Again, same thing. To the ceiling. Look to the side, back to the front, other side. Again, a little further. And side. Touch your shoulder, push it away. Feel the energy. Keep breathing. One arm reaches out long. Bring it together in the middle. Pull it in, throw it away. Again. Breathing out, up and over. Big arc. going to lift the leg up and down and up and down. Let the hands help you lift. Last one. Now just stomp the foot. Just get some energy flowing in the feet. Other side. To finish, expand open. And up. All right. Excellent. Take a breath, in and out. All right, for the second movement sequence, we're going to just kick it up a notch. I'm actually going to show you some of the movement we're going to do so that you have an affiliation. And oops, let's get that back in there. All right, so you're going to start by just stretching the leg out to the heel and in and out and in. That's all there is to it. The second movement sequence builds on that by going out and in. Lift the knee, slap, and down. Out and in and slap. The third movement sequence is just a hop with the knee. Hop one, hop two, slide the foot in. Hop one, hop two, slide. And the final movement sequence is just a click of the wrist. Wrists together. That's it. Okay, so again, comfortable in your chair, seated so that you can actually move out a bit. And here we go. Music, please. Okay, here we go. The first thing is the heel goes out to the front. Here's the second sequence. Goes out, slap the knee. Again. Back to just the heel. Push if you want. Now here comes the knee hop. Hop, hop, pull it in. Hop, hop. Again. Back to the heel. Push. Push with the knee slap. Keep it going. Don't forget to breathe. Hop, hop, slide it in. Hop, hop. Wrists. Shake it off because we're going to go back to the beginning. Heel goes out. Version with the knee slap. Again. Knee hop. Again. Last one. Click the wrists. Whew. All right, take a breath. In and out, and I will adjust. Now, okay. We're going to stand up if we want to. We're going to stay seated if we want to for the next movement exercise. I'll take this moment to talk to you about the Dance for Parkinson's classes. Typically, we meet together face-to-face in a group setting, but obviously we're not doing that right now. So, like so much of the rest of our life, we're doing Zoom classes. And in fact, If you would like to join us, there's more information about Dance for Parkinson's in general, but also about the classes we're doing locally. And that's at the PANC website. So if you go to the website, scroll down to the bottom, there's this awesome exercise picture. Click on the link and you'll find more information about the classes locally as well as the international. Okay, standing up if you want to. So this is some of the movement we're going to be doing. You're just going to step forward and back, and forward and back, forward and back, cross the chest. Now, you do not have to step forward if you don't want. You can step in place, cross the chest. Stepping side to side, boom, 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 boom. Use the arms if you want, or don't. So the thing here is you're going to adapt it to what's comfortable for you. What else? Oh, stomping again. Stomp 2, 3 times. Lift up to the sky and down to the earth. One last movement sequence will be stepping open if you want. The hand shakes up and over, other way up and over. Basically, I think that's it. So again, you have to have a safe environment. You can hold on to the chair if you want. You can have the chair next to you to hold on to. But otherwise, just follow along, have some fun with it. Words to live by. Music, please. Okay. First thing is going to be stepping forward. Forward. Use your arms if you want. Cross. Again. Like a locomotion. Step side. Nice and easy. Arms if you want, or no arms. The stomp is next. Up to the sky and down. Other side. Back to the locomotion. Cross the chest. Keep it going. Keep breathing. Step open. Keep going. Stomp. Press. Other side. Locomotion. Keep it going. Cross. Now, here's the step open. Arm makes the big arc. Other side. We're almost done. Back to the beginning. Boom. Train. Again. Step to the side. Stomp. We're almost there. And up. And down. Whew. Breathe, people. Well, I hope that got your blood flowing and your energy lifted. And I hope you had fun. And I hope that you have a really good rest of the day. Thank you so much. And now, on with the rest of the conference.
Thank you, Kathy. That movement and dance make us all energized. It's now my pleasure to introduce our next session with Dr. Jill Ostrom. Dr. Ostrom joins us from the University of California, San Francisco, where she's a neurologist with a special interest in treating movement disorders, including Parkinson's disease, dystonia, and essential tremors. Dr. Ostrom earned her medical degree from the George Washington University, where she completed a residency in neurology and a fellowship in movement disorders at the Ronald Reagan UCLA Medical Center. She is currently the medical director and division chief of the UCSF Movement Disorders and Neuromodulation Center. After joining UCSF in 2003, Dr. Ostrom helped establish its internationally recognized clinic and research and training center for the treatment of movement disorders. The center has a long history and expertise in treating Parkinson's disease and dystonia with deep brain stimulation systems. Join me in welcoming Dr. Jill Ostrom as she presents Advances in Neuromodulation.
Hello, everyone. It's a pleasure to be here at this year's Parkinson's Association Northern California Conference. I want to thank the organizing folks for this conference for inviting me to speak this year. It's great to get out and be actually teaching again, given this COVID pandemic we're all in. It's been a very unusual time, and I'm just wishing everyone that's watching this conference today that they're doing well and trying to be as connected as they can, given the situation that we're in. It's very troubling. I am going to talk today a little bit about the future of neuromodulation for Parkinson's disease. And I'm going to do my very best to try to cover what I can in 30 minutes. It's a lot to discuss. I have a few disclosures that I have here on this slide for you to just understand about things I'm involved with. Here's the outline of my talk. I'm going to start by talking a little bit about deep brain stimulation, giving you just a simple background so that you have an understanding of kind of where we've been and what the state of DBS is kind of in the past and currently. Talk a little bit about who can benefit from DBS, because that's always an important topic that comes up over and over. I'll try to explain to you some of the expected outcomes from deep brain stimulation, as well as then moving into more updates about things that have happened most recently with deep brain stimulation and what the future may hold. So some of the other topics there are listed below. So the title of the talk was The Future of Neuromodulation in Parkinson's Disease, and some people have asked, well, what is neuromodulation? So I thought I would start by just defining that. Neuromodulation is when you alter a nerve activity through a stimulus of some type, either electrical stimulation or chemical agents can do this, and it has a specific neurological consequence on the body. And so today I'm going to really be focusing my talk on deep brain stimulation, which is a type of neuromodulation. And what deep brain stimulation does is it requires a surgical procedure to place the deep brain stimulation system, and then it delivers electrical energy to these deep structures in the brain, these deep nuclei of the brain that control movement. And this then can have a result in an outcome of neurological symptoms that can be beneficial. It doesn't damage the brain, it doesn't destroy tissue, it instead is influencing these electrical signals in these brain circuits. It's not a cure, but it can result in very meaningful motor changes. So here's a cartoon about just the basic schematics of a deep brain stimulation system. On the left, you can see there is a brain lead, which is labeled 0, 1, 2, 3. And electrical energy can be delivered through any of these contacts, as they're labeled there. And it's connected to a battery that generates the energy. And then part of the deep brain stimulation system allows for you to increase the intensity of the stimulation by making adjustments to the amplitude, as well as to other parameters such as the pulse width and rate. So by customizing the type of energy that's delivered through this brain lead into the brain of an individual, you can influence motor symptoms quite dramatically in Parkinson's disease. So how does deep brain stimulation work? This is complicated, but I like to try to explain to patients that what we're doing is we're influencing the motor system in the brain, which makes sense. How the motor system is laid out in the brain is that you have neurons that arise on the outside of the brain called the motor cortex. And then these neurons then travel down to these deeper structures of the brain in the basal ganglia. And then they feed back again onto the motor cortex. So there's a loop. And there's information circulating through this loop all the time when we're moving. And it's filtering out unwanted movements and undesired movements from maintained movements to help us move as we like. But in Parkinson's disease, when there's loss of dopamine neurons in the substantia nigra, the communication of these loops gets disrupted, and there's pathological signals that are generated, and deep brain stimulation is thought to break up these pathological signals and then restore more natural movement. Deep brain stimulation is not new, and so this is a fun talk to give because I can remember back to when it was really first starting to be applied in this country, in the United States, when I began my fellowship in movement disorder around 2002, when deep brain stimulation for advanced Parkinson's disease was approved by the FDA. So it's now almost 20 years later. So this is not a new therapy. We have a lot of experience with this. There's been these major randomized clinical trials comparing patients who've had deep brain stimulation for Parkinson's disease versus patients who've had just medical therapy being treated with medications. And we see a much better control of off time in patients who have been treated with deep brain stimulation and improved quality of life as well. So what about the current impact of deep brain stimulation on Parkinson's disease symptoms? We have a pretty good handle on how to treat things like tremor. Tremor is very responsive to deep brain stimulation, as well as on-off motor fluctuations. Those can be smoothed out as the deep brain stimulation system is on all the time, as well as we can improve dyskinesia. And in general, patients who have symptoms that are levodopa responsive are going to benefit from deep brain stimulation. Other symptoms that are not so well treated with deep brain stimulation, and this is important so that you don't expect this to be better if you're thinking about having deep brain stimulation, are things like cognition, mood, speech, gait imbalance, and freezing. Those remain really issues that we're still trying to find better ways to treat and manage, and deep brain stimulation has not given us a lot of influence so far in those realms. When patients are thinking about deep brain stimulation, they come to a center, maybe like UCSF where I work, and they go through a candidacy for DBS, a workup. This includes a careful history, a careful examination, reviewing what medications they've tried, making sure there's nothing else that could be kind of reasonably done to help them with medications. That may mean that they don't need surgery if that was the case. They would then have testing in their off-medication state, which you can see here on the left, and also after they've taken their medications on the right. And this way, this is a very good time for us to see the true motor burden that the person is experiencing and how levodopa responsive they are, because we know that's a good indication of a good outcome with deep brain stimulation. Patients will also have a neuropsychological testing to help us identify if there's any cognitive impairment or other issues we need to address. Psychiatric evaluation is sometimes provided, and patients will have a preoperative brain MRI to help with understanding of surgical risks and planning, and then a multidisciplinary team meets to discuss what is best for that person. Here's a few of our patients that have had deep brain stimulation. On the top, you can see what their exam looked like before they had deep brain stimulation. In the patient on the left, you can see he had quite a bit of tremor and congenitally absent right hand, which made it very difficult for him to do things because of the difficulty using the left side. And he underwent deep brain stimulation surgery and had a very successful outcome. And same with the patient on the right, who had really more of a bradykinetic, rigid, no tremor, Parkinsonian syndrome, and she also did very, very well. You can see the speed of her hand movements dramatically improved after DBS without medications. But really, we are in a time of personalized Parkinson's disease, deep brain stimulation care now, and it's become increasingly exciting, but also increasingly complicated. We have many different devices that we can now offer. There's 3 commercial companies in the United States. They each have different features, and so we're always thinking about, what would be the most appropriate device for someone. We'll talk a little bit about that. Also, we think about, do we need to implant both hemispheres of the brain? Do patients have symptoms that are worthy of treatment on both the right and the left sides of the body, or we could just do one? And then what kind of surgical method? And so there's a lot to discuss and talk about. We also have to think about where to place the brain electrode. And for a long time, there's been a running controversy about whether the brain electrode should be placed into the pallidum, or the GPI, or, which is the same, they're synonymous, or the subthalamic nucleus. We have lots of trials now we've done over the years comparing patients randomized to receiving one of these 2 targets. And we really came to the conclusion that they're actually pretty overall similar in their motoric effects and quality of life. We do notice that in patients treated with the subthalamic nucleus have a greater medication reduction. They may have somewhat more cognitive and mood issues. And then we also have found that in one of the later studies that there was a little bit greater motor improvement in the STN. So anyway, they both remain very, very good targets, but it is something we think about because we have to make a decision about which one to implant. And here is just a summary of kind of some of the benefits or maybe limitations of these 2 targets in a review I recently helped write. You can refer to that if you're interested. We have newer surgical methods now. In the past, patients would go to the operating room and be placed in the stereotactic head frame, as you can see here in the middle, and burr holes were created for entry of the small brain lead. And then patients were awoken during the operation where we could then listen to the neuronal signals as we placed a small microelectrode to the target to help us to know where we are placing the electrode to ensure it's in the right place. And this, I think, was very, very successful, but for some patients was scary to think about having an awakener or surgical procedure, or it was also difficult just to be feeling off medications, which was typically performed this way, and to need to participate in the surgery. And so we now have other ways to do this. The surgical procedure can still be done awake, and sometimes is, but we also have newer surgical techniques now, including interventional MRI methods that allow for the patient to be under general anesthesia, and we can visualize in real time placement of the deep brain stimulation electrode, the brain lead as it's reaching its target without the need for confirmation with electrical signals. So a little bit more about these new generations of deep brain stimulation systems. So as I was saying, we now have many systems to choose from, and it's been great because all of these systems now have also advanced, probably because of some of the competition in the field. But the hardware itself is much better. We have smaller neurostimulators, the pocket that goes down here, that connects to the deep brain stimulation brain leads and generates energy. That's much smaller. Some of them are rechargeable, so that's been great. If people needing battery replacements every 3 to 4 years, they can now opt for a rechargeable system, which is pretty efficient and needs limited charging perhaps every couple days, or in some systems just every week. So that's been nice, and the smaller battery profile just also means probably less infection risk. We also have seen changes to the brain, the electrodes themselves, the lead, and we now have fancier ways in which we can deliver electrical energy to the brain. I'll talk about that in a second. Also, some of the devices are now MRI conditional, meaning that before it was not safe to have a deep brain stimulation system in and then have an MRI. Now the newer systems are conditionally approved to be safe with 1.5 Tesla, and in some systems 3 Tesla MRI machines. So that's been great, and not just for the brain, but for the whole body. So if you need to have an MRI because you have low back pain, it's now possible. There's also newer features, including directional programming, which I'll talk about again. So the software that's associated with this hardware is improved. Volume of tissue activation imaging is really coming now. We can now predict better when the battery, if you don't have a rechargeable system, might need to be replaced, which is really reassuring. And we have other advanced features like brain sensing, digital diary, and then very soon closed loop adaptive stimulation, which is right now just used in research. So let me walk through that for you a little bit. This is really where the future is going. But just to look back, I love this slide because it reminds me of kind of where we've come. So on the top there, that's the first generation Medtronic clinician programmer. And we used to carry that around, our clinics, and it was very, you felt like an FBI agent or something. It was very clunky and big. And you can see the evolution of the physician programmer. Now on the right bottom, we have a tablet-based system. At least this is one just showing how far Medtronic has come. So it's really become a modern era kind of technology. Here's also a slide to just highlight what's happened with the brain lead. So in the past, again, if I had a pointer, I would show you on the left, you can see the deep brain stimulation lead has kind of 4 black squares. Those really are cylindrical leads. They're going all the way around. And so you could activate either C0, C1, C2, C3 to deliver energy to the brain within millimeters of what you would like to help someone's symptoms. You can tailor that. And now we have electrodes that, as you can see, perhaps in the two middle segments there that are segmented so that you can deliver energy just on one side of the brain lead. So now not only can you go up and down the electrode by using energy, you can also laterally shift the stimulation. So here's kind of another way to try to explain this. You can see on the top row there where it is kind of highlighting more of a green or red. That's where the energy is shifting. So it's not around the whole lead, but it can be moved laterally. So this is nice if you're trying to avoid a side effect of stimulation. Perhaps you're too close to fiber tracts that are affecting your speech. You may be able to now move it laterally away, but still improve motor symptoms. Also, we have these software packages that are coming, and they are going to be using patient-specific anatomy and then laying the brain, the deep brain stimulation lead on top of that patient-specific brain anatomy. And then you can infer what area of the brain you're actually stimulating on top of the imaging. And so this is nice to have more of a visual feedback of, well, where am I stimulating? Should I move a little bit up or down, or maybe it should just be less to not influence nearby structures. And so that's going to be a real advantage, I think, coming soon. We also have something now, which is very new as of this summer, called brain sensing. And this is really, we could spend a whole 30 minutes just talking about this because it's very exciting. But what this allows us to do is to take us, not just deliver stimulation to the brain, but actually record from the same electrode that's delivering this stimulation to the brain. So this is pretty different than how we usually think about deep brain stimulation. But you can think about the analogy of a cardiac pacemaker. Pacemakers now can record heart rhythms as well, and they can actually just discharge perhaps when there's an arrhythmia of the brain. And this is now what we are able to do with deep brain stimulation systems. In certain systems, we can sense what's going on in the brain. So movement disorders, including Parkinson's disease, are becoming really electrophysiological disorders, somewhat like epilepsy has been for a century. We've been thinking about recording epileptic seizures, but we can now start to decode what is going on in Parkinson's disease. So what does this look like? Here's a patient who has deep brain stimulation. The white arrows there are are indicating where the brain lead is on the MRI. And this person has then, we are sensing across this, it's able to take off a summation of kind of how much the neurons are firing together and how quickly they're firing together. And this can give you an oscillatory frequency of how fast they're all kind of working together. It's a little bit confusing to explain, but I'm going to do my best. I think the way I think about this when I try to explain it to someone who's not in neuroscience is that you have these neurons that are communicating together and they're firing together, and then you can break that down and say, well, how quickly are they all firing together, or how slowly are they all firing together? And one thing we've been able to find out so far is that in the subthalamic nucleus, for example, when patients are experiencing Parkinsonian symptoms, when they're off medications, the neurons in this area, they fire at a certain frequency. So the red line there on the bottom is kind of showing you the power of the neurons, how the higher they are on that graph indicates that there's more of them firing at that strong, in a strong way at that frequency. So we see this signal over and over again, and we know when we treat patients with Parkinson's with medications, then that signal goes away, and you can see the black line where it's sort of lowered. I hope that you can understand that a little. So now we have this signal. We call it the beta band signal. So when the beta band in the 20 hertz is high, we think that's when patients are experiencing more Parkinsonian symptoms, and it's an indication that we're in the motor circuit. You could then just say to yourself, well, which electrode should I stimulate off of? We might be able to use that electrode signal to determine which electrode to turn on and deliver therapy through. And this is just some recent work by Andreas Horn, and has kind of thought about this, and this is just showing the subthalamic nucleus divvied up. It's a very small nucleus, but within it there are different subparts, including a motor area where you want to be stimulating. And we can now just sense from that area perhaps, and then turn on that electrode. And we don't have to just try things so much anymore. We can actually be more focused based on these signals. We also can measure what's going on with these signals over time. And we're still trying to understand how this might be best used in patient care. But if someone were to come into the clinic and we had a record of what was going on with this signal, we could say, oh yeah, it looks like you're still really fluctuating in your symptoms. I can tell that by looking at this brain sensing signal. Or perhaps you could say, I should turn up the deep brain stimulation amplitude more because there's still a lot of Parkinsonian signal here. So we're thinking about how to use this information, and it's helping us to decode what's going on. But what's most exciting is that once we can figure out what these brain signals are telling us about Parkinson's disease or other aspects of how the brain is working, when we can decode them, we can then use them to determine whether something is beneficial or not, and then trigger off that to then adjust the deep brain stimulation. And so the hope of this is that we'll have more auto-programming someday for deep brain stimulation, and this is being called adaptive deep brain stimulation or closed-loop DBS. This is not available yet, but it is being done in many research protocols, and the current Medtronic device actually is capable of doing this someday with a software upgrade if the FDA were to approve it in the future. So here's an example of someone who is in a research study of ours at UCSF. She has a research deep brain stimulation system that also allows us to sense brain activity, but also to adjust her stimulation because she's in the study. This is under special work still to try to help us to understand how this could be done in the future. And I just thought it would be interesting for you to see that here she is, she's at home, and we are able to, while she's there, do remote streaming of her brain rhythms. So we are now in an era where we can have people at home with these research systems in place, and we are gathering brain signal information and trying to decode this. And it's really kind of been remarkable to be able to continue this kind of research even during COVID times when we're all apart. Okay, so that's really interesting and exciting. I also wanted to just remind people that we are seeing in China, actually, our colleagues in Beijing have recently published this little review on their experience with a different kind of deep brain stimulation system that allows for remote programming. So in the last slide, I was talking a little bit about how we can remotely record brain signals, and we're decoding that and trying to understand what that means. But here they actually have a system that would allow your DBS provider, your neurologist, your nurse practitioner, whoever's doing the programming, to just be in their office or wherever and log into some system that then can communicate to your DBS system at home. And they could make programming changes over a secure cloud-based server. So this is happening already in China with the systems there. And we may be seeing this soon in the US too, which would really be nice for patients who have poor access to programming. I wanted to also just highlight that as you all know, there's ways in which we can measure objectively movement and other things now using other sensors. We could have a peripheral sensor on our finger or on our hand. We could measure how quickly we're moving just with an accelerometer. And now we have brain sensing technology that can help us to know whether those are correlated. So I think we're going to start seeing some peripheral sensors as well used to help us inform whether we're moving, whether we're dyskinetic, whether we have tremor, and correlating that with some of these signals we're seeing in the brain. And that will help us to be able to use DBS more efficiently. Also quite interesting is the idea that if we could record some kind of signal, perhaps think about a tremor, using just a hand accelerometer, that we might then be able to find a way to phase cancel that within the brain to minimize tremor. So this is getting a little bit out there, but it's actually kind of part of what we're working on now. I mean, it's not ready for prime time, but this is really some of the future, I think, of how we're going to be using this technology now to maximize the opportunity that we have with sensing. And then lastly, we still need to be able to figure out what is really happening with patients when we're sensing and decoding these brain rhythms. And so the more we can get a sense of if the person's state, and if you're out walking around in the world and we're sensing your brain rhythms, doesn't mean very much unless we know in what context that is. So this is just some other fun work we're involved with now, where we can take videos and we can measure how quickly someone's moving their fingers, for example, which is relevant in Parkinson's disease because it's synonymous with bradykinesia, but it could also be done for tremor or things like that. And we can get an automatic reading of just a video now. Or you might imagine someone's speech. We could have a sense of, if they're having hypophonia, and what does that mean, or if they're having more slowness of movement while walking, and also using apps to just understand, how are you feeling, trying to get at other non-motor symptoms that may also be important and may be helpful if we could correlate with certain brain rhythms. So lots and lots of work is happening in this arena right now, and it's just the beginning, but I think a lot of this is coming in the near future. So just to summarize what I've tried to cover today, I tried to go back and give you a little bit of context for patients who may not be as familiar with deep brain stimulation, just so you could get your head around a little bit about how it's used and how important it can be in terms of treatment of motor symptoms, who might be a good candidate. I tried to talk to you a little bit about the systems we have now, and to try to cover what is really recently come to pass in terms of what kind of tools we have to use, and then tantalize you a little bit about what's coming. It's really a great time for neuromodulation, deep brain stimulation, and Parkinson's disease. It's never been so exciting, but it is moving fast. I think what's going to likely happen, though, is that we're going to have even better outcomes. We're going to have smaller systems, we're going to have less complications, and we'll be able to be even more targeted to individual outcomes. And I think we'll have, there'll be better access to this kind of complicated therapy. so that we have more efficient programming optimization, and we can then even track and really try to understand more and more about what's really going on in the brain in Parkinson's disease. It's a time of great discovery. And then lastly, there's wearable technology, these apps and things like that, as it's moving into all kinds of medicine right now, is really going to help us to continue personalizing deep brain stimulation and Parkinson's care. So with that, I'll just end with a concluding slide recognizing the UCSF movement disorder team. We're a big team. We do a lot of excellent clinical care, and we also do a lot of excellent research and teaching. We have a large fellowship program. If there's anyone interested in reaching our clinic, I put the phone number and our website down there in the corner. And we'd be happy to help in any way. We're doing lots of telemedicine right now, which is a great way to get plugged into the clinic if you don't want to come in. And then one just plug for a study that I'm involved with, really led by Dr. Carolyn Tanner at UCSF, who's also a big advocate of this organization. And she's helping to do this important study to try to reduce fracture risk in Parkinson's patients. So if anyone is interested in participating in this really important study, it's a completely at-home study, and it's very simple to participate, but we're looking to enroll thousands of patients with Parkinson's, so that's why I chose to just highlight it here. Hope that's okay. Thank you very much.
Thank you, Dr. Ostrom. What a fascinating presentation. My name is Dr. Eric Egley. I'm a psychologist and a member of the board of PANC. We now have the pleasure of listening to a panel of experts led by Dr. Norika Malhedo Chang. She is an associate professor of neurology at the University of California Davis School of Medicine in Sacramento, California. She studied neuropsychology at New York University and graduated from Mount Sinai School of Medicine. She completed neurology residency at Mount Sinai and stayed on for a 2-year fellowship in movement disorders and deep brain stimulation. Dr. Malhedo Chang is in her 13th year on faculty at UC Davis, where she directs the clinical clerkship and sub-internship in neurology. Her passion is Parkinson's disease and teaching learners at all levels, sharing her enthusiasm for neurology, Parkinson's disease, doctoring, and education. Her greatest joys are inspiring students to pursue a career in neurology, training them to become stellar physicians and top-notch Parkinson's specialists, and welcoming them to join her as faculty and co-teachers for the next generation. Also, of course, getting to know her patients well and helping them and their families navigate life with Parkinson's in the richest way possible. We are so pleased to have Dr. Malhedo Chang to moderate the panel discussion today.
Hello, everyone, and thank you so much for joining us this year's PANC Educational Conference. I'm so glad PANC was able to host this very popular event again this year, despite all the challenges, and I am honored to be able to host this expert panel. I'm really, really glad that we have this opportunity to connect with you all, at least virtually. So first, I'd like to introduce the experts that I have invited from all over the Sacramento region, and I'd also like to tell you a little bit about my theme for this year's panel discussion and tell you a little bit about my vision for comprehensive Parkinson's care. So this year, my theme for the panel discussion is multidisciplinary care. And what that means is embracing a model of healthcare that harnesses the expertise of a variety of specialists to truly provide comprehensive care for the whole person. And in the past, a person with Parkinson's might have all their medical issues managed by their primary care physician, and that may have been okay in the past, but what turns out is that it's challenging because Parkinson's, by definition, is a very complex condition. And so now we have not just motor symptoms to contend with, but we have a whole host of non-motor symptoms as well, like constipation and sleep disturbances and anxiety, depression, speech and swallowing issues, to name a few. So as our understanding of the field has progressed, we now have subspecialists to help us manage each of these different facets. Here in Sacramento, we are especially fortunate because we have a phenomenal array of resources and talent in the field of Parkinson's, and we should capitalize on these skills to really provide patients this team approach. We have 4 very strong healthcare institutions, and I've purposely tried to represent all 4 here today. We have Kaiser Permanente, Sutter, Dignity Health, and UC Davis. So without further ado, allow me to introduce our panelists for today. I'll start with Marty Mooney-Conkle. Marty is a speech and language pathologist at Dignity Health. Marty specializes in LSVT and works with the Parkinson's community on therapies to help both speech and swallowing. She works out of the Mercy Outpatient Rehabilitation Center in Citrus Heights. Welcome, Marty.
Thank you so much for having me.
Next, we have Dr. Beverly Chang. Dr. Chang is a wonderful local psychiatrist who has really dedicated her life to taking care of the geriatric population and those with chronic neurodegenerative conditions like Parkinson's. She's well positioned to address many of the psychiatric comorbidities of Parkinson's at various stages of the disease. And her private practice, called Geriatric Psychiatry Direct, is located in Rockland, but she's also very familiar with telemedicine as well. So welcome, Dr. Chang.
It's a privilege to be here. Thank you.
Next, we have Sarah Panasco. Sarah is a physical therapist representing Kaiser Permanente. She specializes in working with Parkinson's disease. She's very experienced neuro-PT for 7 years. She's very passionate about educating her patients and their families in terms of the best ways to improve daily function and mobility. And she works out of Kaiser Roseville with Erin Vestal and Christine Shade, which many of you have met at previous conferences. All of them are just really dedicated to evidence-based practice when it comes to Parkinson's disease physical therapy as well as exercise. So it's great to have you, Sarah.
Thank you so much for inviting me. I'm so happy to be here.
Next, we have Erin Lavin. Erin is a senior neurosciences dietitian and inpatient nutrition services at UC Davis. Erin has special interest in Parkinson's disease, and she's very passionate about community outreach. Erin has been a featured speaker for our support groups at UC Davis and also recently helped me co-write a newsletter article for the PANC Parkinson's Path. Erin will be able to answer questions about diet, nutrition, and supplements. So welcome, Erin. Thank you for being here.
Thank you for having me.
Next, we have Mrs. Carolyn Loveridge. It's an honor to have Carolyn back on the panel this year because Karen brings an immense wealth of wisdom and experience to the table. Carolyn's late husband had Parkinson's disease, and so she is very well versed in what it means to live well with Parkinson's and also how to take care of someone as a caregiver. I'm excited to learn some tips and tricks from you, Carolyn. Thank you very much for coming back.
Thank you. I appreciate the opportunity.
Next, we have Erin Kite. Erin is representing Sutter, and Erin is a social worker with a broad experience in Parkinson's disease, palliative care, and hospice. She's been working directly with the movement disorder team at Sutter Neuroscience in their outpatient clinics in both Roseville and Sacramento for the past 2 years. And Erin provides patients with resources, support, caregiver planning, and counseling. Erin is also actively involved in community outreach as a medical advisory board member for PANC. Welcome, Erin.
Thank you for having me.
And last, but certainly not least, we have Dr. Joshua Dayananthan. Dr. Dayananthan is a movement disorder neurologist at UC Davis. He graduated from UCLA and then went on to medical school in Ohio. I first met Josh when he did his residency in neurology at UC Davis and then stayed on to complete a fellowship in movement disorders with us as well. And Dr. D, as your patients lovingly refer to you as, he specializes in the diagnosis and treatment of patients with Parkinson's, and he's also very involved in clinical trials research. Welcome, Josh.
Thank you for having me. I'm pleased to be here.
Absolutely. Oh, and Josh, with 3 daughters at home, is certainly no stranger to strong women, both at home and in the Parkinson's community. So what a group. Thank you all so much for being here. I'm so thrilled to get started. I also wanted to thank you all because you submitted fantastic questions when you registered. And I went through those questions and wow, I was really blown away. I really want to try and get to as many of those questions as we possibly can. So let's get started. One of the questions that spoke right to me was directed at our theme, which is multidisciplinary care. And the question was, when is it appropriate to involve a team like this? Is this for advanced Parkinson's disease, or is it also applicable to the newly diagnosed? So Sarah, as a physical therapist, I know you embrace the lifetime model. Can you tell us what that means and how physical therapy applies to people across the spectrum?
Yeah, so we've been so lucky as time has gone on. Initially with Parkinson's, they advised people not to exercise, just rest. And then we found out that, oh man, that was actually a horrible idea. What we need to be doing is getting people moving. So with physical therapy now, we have the opportunity to evaluate someone early on in the disease process. I mean, as early as possible. And then we can get a benchmark for where you are with balance and strength and mobility. And then over the course of time, you can come back and do those same tests and we can see if anything pops up, even a mild abnormality, and address it before it becomes a huge problem. So I know our model is very similar to that of a dentist, right? You come in, you get checkup. If there's anything going on, we can manage it. If not, I'm going to see you again in 3 to 6 months. Right, so it's so wonderful to be able to follow someone and develop a more personal connection with them over time. And I will say it also gives me a unique position to say, hey, your voice doesn't sound quite as strong as it did last time I saw you, or I noticed you cough a little bit on water in the waiting room. And so it gives me a chance to pick that up and kind of go over to something like speech therapy when I notice it starts to be an issue.
Fabulous, fabulous. And Marty, you also embrace the lifetime model. So tell us a little bit about why it's important for someone to work on their speech and swallowing at all stages.
Yeah, sorry. So we do exactly what Erin does, that we want patients to come in as soon as possible because then we get our benchmark or our baseline level of how they're functioning. And then you know, quality of life, a big part of quality of life is communication and eating, right? And so we want to get in there in the beginning and help you to maintain those quality of life and exercise, again, just like Erin said, exercise is the key. And so we get you on exercise programs to keep those skills as high up as we can. And then we do the same thing that we ask you to come back in, or more like 6 months, but 6 to 12 months to check back in and see how you're doing and if we need to jump in and modify your home program or whatever it is.
Fabulous, thank you so much. Dr. Dianthan, you and I, we call each other movement disorder neurologists, right? But as we're learning more about this disease, it seems like it's becoming a little bit more of an outdated term because initially Parkinson's was felt to be a condition primarily affecting mobility, but there's so much more than that. That's just the tip of the iceberg. So what are some of the other non-motor symptoms that we have to help patients navigate?
Absolutely. As you were saying, we really need that multidisciplinary approach because there are so many non-motor symptoms that can affect an individual with Parkinson's. Things from gastrointestinal issues with constipation, overactive bladder, sleep-related issues with things like REM sleep behavior disorder or restless leg syndrome. Just to name a few things, cognitive changes, mood changes with depression or anxiety. So it really touches on the whole person, and you really need that team approach to help address all of these issues a lot of times.
Yeah, for sure, for sure. Thank you. But Erin, we know that our audience has a lot of questions about diet and nutrition, supplements, Perhaps you can tell us a little bit about what constitutes an ideal diet for somebody with Parkinson's, and what are some of the nutritional concerns that might come up?
That's an excellent question. So when it comes to when I'm interacting or working with somebody who has Parkinson's, I like to focus on what their goals are first. Are we looking at how can I eat in a way that may delay disease progression? How can I eat in a way that helps me with symptom management? And we focus on what your goals are so we can see how we can tailor your nutrition to work for you the best way it can. So when it comes to looking at nutrition in terms of delaying disease progression, Dr. Mishi, who spoke at PANC, I think last year, she talked about, she's doing some research looking at that, looking at observational studies and seeing what types of foods best delay Parkinson's and how can we do that. And a lot of the research that we've seen is that eating a diet with fresh fruits and vegetables versus especially avoiding canned as much as possible, but fresh fruits and vegetables, eating fish at least once a week, eating lots of whole grains, lots of fiber, and that also kind of plays a role with symptom management as well. So constipation is often a big struggle with Parkinson's and can even precede a Parkinson's diagnosis by several years. And managing that also helps with increased fiber intake, so whole grains, fruits and vegetables again, beans, nuts, those are all wonderful foods that can aid in constipation management. And as we're learning more about the gut and the brain and their intimate connection, we're also looking at microbiome modulation. And fiber management is the best way to modulate your microbiome, to feed those good bacteria, to make them work their best for you also. So all of these things kind of play a role and integrate well together. So one of the best things I would say is increase your fruits and vegetables, increase your fiber. Let's start there. And there's even some small data, but some research to show that even like psyllium husk, which is found in Metamucil as an example, or just increased fiber, especially in the morning, may help modulate your levodopa levels throughout the day too. So really finding what can we do to work with your Parkinson's, what are your goals, and what is most pressing right now.
So you mentioned fiber. There's, I tell patients have a lot of fiber in your diet, right? But what are the best ways to get fiber?
Excellent question. Some of the best way, foods also always my first preference, so whole foods, because each type of fiber feeds a certain type of bacteria or certain microbe. So like if your microbiome was the ocean, right? We have sharks, we have whales, we have dolphins, and they all eat something a little bit different. And we want a big, healthy ocean with all these different creatures in it. So eating a wide variety and indulging in a wide variety of foods in like kind of that rainbow theme really feeds these different bacteria. And there's a lot of research looking at the MIND diet, which is the Mediterranean diet intervention for neurodegenerative delay, which Mayo Clinic likes a lot. It's very wordy, so we go with MIND, or like a Mediterranean style diet, but really just lots of fish, lots of fresh fruits and vegetables, lots of fiber, lots of whole grains, quinoa, beans, nuts. Those types of foods actually specifically for Parkinson's increase certain bacteria populations that people with Parkinson's tend to be deficient in or have lower levels in. And I would not necessarily recommend a probiotic because some people with Parkinson's already have higher levels of the lactobacillus and the bifidobacteria. So we don't necessarily want more of those popular probiotics, but those whole foods give us a better picture because we don't want just sharks and whales in the ocean, right? We want a whole glorious critter, feast of critters in there. And so foods are really the main way from a microbiome approach specifically to make it work the best for you.
Great. Oh, I love that analogy. That's awesome.
Thank you.
Well, be sure and look at the Parkinson's Path, the summer issue, because your article that you wrote was really good. And then there was one other article in there that relates to it on when to eat and when to take your meds, and to help those balance out and give you better results. So I'm the editor. I want you to look at it.
Yeah,
Thank you.
Thank you.
Yeah, actually, Carolyn, thank you so much. If you haven't seen them before, please look at the Parkinson's Path. You've put a lot of work into that, and there's some really, really great informational articles in there. And while we're talking, Carolyn, you've really lived this, right? Parkinson's was your life.
Absolutely.
You have really such a wealth of real life experience. And diet, as I'm thinking about it, you are probably the one, a care person, and the care partner is the one who's in charge often of preparing the foods. So what were some of the more challenging aspects of being a care person? And maybe you can give our audience some advice from somebody who lived it themselves.
Well, I think you don't get discouraged, and you try to cater to your person with Parkinson's, and help them feel like you are paying attention to their needs, and you just fill them in with good food. One of the things as Parkinson's progresses, a lot of things happen as you end up drooling, and probably the best thing I did was I had a nice big bib that collected the drools and kept your clothes clean, and it was very helpful. And I passed them on to friends, and that's the one thing I passed on that everyone says thank you for.
That's great. That's great. Thank you, Carolyn. Next, let's go to Dr. Beverly Chang. So Dr. Chang, you are a psychiatric expert here, and what are some of the more common emotional symptoms that accompany Parkinson's disease at various stages?
Great question. So I like to think of anxiety and depression being two main things that I see a lot of in my office, and I make an analogy to the same thing that happens with the GI system, where oftentimes those can be presenting features of Parkinson's. So I will frequently see people that maybe have had a history of depression or anxiety at some low-lying level, and then years before they're actually diagnosed and exhibit tremors or other symptoms, they will say that they've had a particularly worse episode of depression, or the anxiety is just a little bit different. And that is because the same neurotransmitters that are involved in Parkinson's are also depleted for anxiety and depression. And it makes it very difficult sometimes, unless there's a specialist involved who's familiar with Parkinson's, because the symptoms of depression can very much overlap with symptoms of Parkinson's. We have the restricted facial expressions, the slowed thought processes, cognitive issues, just lack of motivation, lack of energy. And it's part of my job to tease out what is depression, what is solely Parkinson's, and it's just very difficult to do that. And so I will often look at things like hopelessness, worthlessness, and that sounds not good, but a lot of times people that are diagnosed with Parkinson's do experience these feelings, and it's just a good thing to have somebody on board on the team that can address these, because it really is a journey from pre-diagnosis all the way through the different stages of Parkinson's. And we have medications to treat that too, the SSRI, selective serotonin reuptake inhibitors, which some of you may have heard of, and there's those and a variety of other agents. And then the anxiety is a whole other world in itself as well. I'll hear the comment a lot that, from the people that may have had generalized anxiety before, what will it be like 10 years from now? How will this progress? Or perhaps they're a little bit more self-conscious now because of a tremor, or at the dinner table type of thing. And then we get into physical symptoms of anxiety, which are also difficult to tease out from Parkinsonian symptoms, because this can coincide with anticipation of a medication wearing off and freezing. So that factors in. And sometimes I've even experienced patients that have full-blown panic attacks. What is a panic attack? It's when the heart starts beating very rapidly. There's a sense of impending doom, like the walls are caving in, people can't breathe, might get a little bit sweaty. And we have medications for that too. The difficulty is that we always have to balance medication side effects versus what they provide as benefits. And a lot of the meds can have unwanted side effects, so I take that into consideration as well. And that's pretty much what I see a lot of.
Thank you, Beverly. You mentioned depression. Apathy is also a big issue too. So what is the difference between apathy and depression?
Thank you. I forgot that because it's a very important point to make. Apathy can be a symptom of depression, but it can exist on its own. Apathy is associated with any kind of neurological insult, and what we see is just amotivation. So frequently, when you ask a person with apathy, are they depressed? They'll say, no, everything's fine, but yet they'll exhibit symptoms of depression, like they won't engage in anything. And this is so exacerbating for family members. Carolyn, I'm not sure if you experienced this as well, but I think my best advice for people with apathy is to not get too stressed out, because that also feeds back into less good health outcomes for both the person affected as well as the family members or loved ones. Routine is always good, having a regular schedule. And even if somebody isn't completely involved in an activity, it's good to stimulate their senses. Not overly stimulate, of course, but even being in an observational role can be helpful for apathy.
Yeah, so that is a very common question that has been coming up from our audience. And so it sounds like the management is not necessarily the same as how you would treat depression. Is that right? So maybe not the same, or would you use the same medications, or maybe more of a lifestyle or behavioral change?
Definitely lifestyle behavioral change. And if depression contributes to apathy, it's definitely worthwhile to treat that. It probably won't resolve all of the apathy that we see. And I have some families that come to me inquiring about something that'll just perk up a family member. And sometimes those will work. They're typically stimulants, but those also have unwanted side effects in the way of raising blood pressure, raising heart rate, making somebody a little bit overly anxious also.
I would make a good argument for exercise as a way to boost that. And I loved what you said about routine, just because so much routine can go into exercise, and people with apathy tend to be more responsive to group exercise, just as a plug for all of our lovely, rock steady group exercise, PWR classes, because they have this schedule and kind of community built in that now it's not just about doing something, it's an obligation that now is on the schedule.
I could not agree with that more. I think that's fabulous. And I think what that does is it's not, a care person nagging or the doctor nagging, but it's you are with your peers, these are your people, and you can all do it together, right? So I think that's a really, really great strategy to use the group exercise to try and combat apathy, because there's nothing harder. I mean, the feeling of not being motivated, not having that initiative to do all the things you have to do, right? To try and slow down progression of this disease. So I would definitely feel that depression, anxiety, apathy, psychosis, these are some of the hardest, most challenging symptoms in Parkinson's overall. And it puts a significant strain not only on the person experiencing it, but also on the care person, the spouse, the loved ones. So I want to go now to Erin Kite, who is our social worker, and maybe you can tell us a little bit about how a social worker can help navigate these challenging symptoms.
Yes, of course. Well, as a social worker, we are available at all stages, and it's actually great for us to start when somebody's initially getting diagnosed or starting to have some symptoms, because we can start talking about long-term planning. We can talk about advanced directives, what are some of the individual's goals, and having those conversations with families. And then as things continue to change and progress, that can cause some stress on the caregivers and the family, and looking at resources at that point and being able to identify what can we do to support this family, more than just the individual, but the family is a big piece of that too. So throughout the whole process, social work can be there to help connect with those resources, provide that support, and get you connected to the people that you need through this journey.
Great, great. Can you give us a sense of what kind of resources? Because we keep hearing that there's resources out there, but people ask me, where do I find them? How do I tap into them? What's available?
There's actually quite a few resources. The PANC is actually a great resource. If you go to their website, they have a lot of resources alone. They have support groups. There's the Parkinson's Wise classes. There's all kinds of resources. There's Del Oro, which is a support for the caregiver of someone with any kind of memory issue. So they actually focus on support for the caregiver. They can do one-on-one counseling. They also talk about support groups. They have some case management. They can help with legal services. There's so many different options out there.
Oh, that's great. That's really great. How do we know when it's time to call in for extra help? I think that's a really tough one, right? Because we're, a husband and wife, or have been a team for years and years, and all of a sudden it might seem like we need some extra help. How do we know when to call in that extra help? And then where do we go for that? And this is both for Carolyn and for Erin.
Sure.
Okay. Well, I would say get to a support group. And support groups right now, many of them are on Zoom because we're not meeting in person. But at a support group is where you find out all sorts of resources and where to connect with other people and the things that are available. So participate in the resources, in the support groups. I continue to participate in the caregiver support group, even though Arnold has passed on, because sometimes I can make a contribution, but they nurture me as well. And so participate as a caregiver in a caregiver support group, participate as a person with Parkinson's in the regular support group. In fact, the Parkinson's Path that's coming up, it'll be to you right after the conference. Dr. Chang has an article in there on apathy. And there is an article from a person with Parkinson's and talking about how she and a group put together an exercise group that does both physical exercise, loud, big, and she talks about how they feel obligated to support one another and how much she called her article the silver lining. And it truly is inspirational. So don't wait for someone to come to you. Get out there and try. And look at the Parkinson's Path. Those are all posted online at panctoday.org. And so you can go back through issues that have been available in the past as well as current ones.
Great. Thank you, Carolyn. Erin, I think you also have a few things to say about caregivers and maybe help in the home, help outside the home.
Sure. Yes, and actually a good place to start is actually just talking to your provider, talking to your neurologist, and starting the conversation with them, because they can then connect you with your social worker, they can connect you with your nurse and with your team, and from there you can work together as a team to figure out what the best option for you would be. There's so many different resources out there for support for families. You can hire caregivers at home. There's facilities. There's day programs. There's respite programs. There's all kinds of options that are available. And so I think talking to your team is a great place to start.
Great. Great, thank you. Thank you so much. Another question that comes up quite a lot is, how do I get involved? What if I want to participate in research or participate in clinical trials? So I'm going to bring it to you, Dr. D. Maybe you can tell us a little bit about how patients can get involved in research.
Sure, I think the first step is to voice your desire to get involved in research with your neurologist and kind of get the ball rolling there. They should be able to at least outline what their particular institution has in regards to research for Parkinson's. We commonly utilize a website, clinicaltrials.gov, to help find research studies if we're not a site for a particular study, whether there's a nearby site that may be a good fit. And your neurologist will be able to kind of assess whether you're a good candidate for a study because given studies are looking for particular characteristics and age range, sometimes a particular stage of diagnosis, certain medications that you've been tried on to see if you're a good candidate. One thing, just touching on the subject of research, I always advise patients that really the big desire that someone should have to be involved in a research trial is to help contribute to the science. You know, we're doing these research endeavors in order to find out if a treatment or a new drug of some kind is helpful in this patient population, but we don't know on the front end if it is going to be helpful. So really, that's the purpose of doing those studies, is to find out if that intervention is useful or not. There is some indirect benefit that people get from being in research. You get more clinical attention, you get more frequent visits, but really that true push to be involved in a clinical trial should be that you want to contribute to the Parkinson's community and to the research and to the science behind it.
Great, absolutely. And I know that from even at UC Davis, we've got trials going on at all different stages. So for some of them, you don't have to change your medicines. For some, you might have to. For some, you can do them at home, right? You don't even have to leave home to participate.
Yeah, Dr. Ostrom talked about that TOPAZ trial that is recruiting currently, looking at a treatment for osteoporosis in Parkinson's disease to help prevent fractures. And the interesting thing about that trial is that you can do the majority of the visits from your own home. And they'll actually send a nurse out to do the assessments. So that's a very interesting and innovative way to conduct a research trial, but a lot of them do involve coming into the clinic very often for visits. Another one that we have is the RESTORE trial, which we're a rating site at UC Davis paired with the surgical site at UCSF, and that's a study looking at a viral vector surgical implantation of a amino acid decarboxylase, which is actually something that's deficient in patients with Parkinson's disease that can make their levodopa less effective. So giving that enzyme actually can make it more effective, or at least that's what we're hoping in those patients that are enrolled in that.
So how should people contact, if they want to get involved, who do they contact?
Yeah, we have great research coordinators. If you contact your neurologist, they usually can get in touch with one of these research sites, and then they will reach out to their research coordinator, who will then contact the interested applicant for that study.
Fantastic, excellent, thank you. Speaking of research, I know there's a lot of research in the field of supplements. We have a lot of questions coming in about supplements and their utility in Parkinson's disease. Do you want to touch on that and tell us what you know?
Absolutely, yeah. There's an amazing amount of research about any variety of supplements and Parkinson's, and that's pretty common with any neurologic or neurodegenerative disease. And some of the more popular ones would be CoQ10, so coenzyme Q10. And I would say the research on that, it's relatively inconclusive so far. The largest randomized controlled trial was published in the New England Journal of Medicine in 2014, and they didn't find a huge benefit with that. With most supplements, for the most part, there's very little risk involved, but you always have to be mindful with medication interaction. So turmeric supplementation is another popular one, but turmeric can kind of compete with other medications for absorption or limit their efficacy. So do be cautious with that one. It's better just to enjoy curry. Curry is delicious. Eat curry regularly. I would be my suggestion there. And then similarly with fish oil, another relatively low risk supplement that may have some benefit to it, but some of the drawbacks with like any of these supplements, like so fish oil, if you like take the capsule of fish oil and you look at the fish, like these are not quite the same. So there's compounds in fish that help your body utilize the omega-3s and have those become part of your cell membranes and make your brain work a little bit better. But you don't necessarily get that in the fish oil. So we don't necessarily have all those pieces of the puzzles figured out. So supplements may never be quite the same as food, but there is definitely some research with maybe fish oil and helping out with maybe some of the depressive symptoms, or just maybe including those foods is a good place to be. And then if you're finding that
it's getting hard to eat those fresh fruits and vegetables, and it's getting hard to get those variety of foods because you're getting tired, or it's getting more difficult to eat those. Making sure you're getting enough is never a bad insurance plan. So like the B vitamins are ones that have been looked at in Parkinson's, and the fish oil, and vitamin C is one that's sometimes talked about too. So if you're finding that you're not able to get that variety in nutrients, then yeah, it may not be the worst idea to have one of those back up just to make sure you have enough, because those are some of the levels that we look at when somebody comes in into the hospital who's a little confused. We're usually checking a B12, we're checking a B1 level. So making sure you have those is not the worst idea. And again, with probiotics, like I can't say I would recommend those at this point. I think the gut-brain axis with Parkinson's is blossoming in research. It's incredible. But I went to a microbiome symposium a couple months ago, and I like what they said when they said, we're at mile 1 of 300,000. You just got to bear with us. We're not there yet. The marathon is just beginning. But again, like the best research we have for modulating microbiome is with food. So if you want to know what can I do to get my bacteria working hard for me, is to eat the fiber and give them the fuel they need to work their best for you.
That's great advice. Thank you.
If I could touch on something, thank you, Erin. But one thing that comes up not infrequently for me are dopamine boosting supplements and whether those are appropriate for patients. I usually counsel patients to avoid those, especially those ones that are the Mucuna Purion supplements, given some concern that they could potentially interact with our other dopamine boosting medications. I also have concern that supplements aren't regulated as much as pharmaceutical medications, so they're not subject to FDA scrutiny as far as potency or other additives to them. So that's something that I steer patients away from, especially those Mucuna supplements.
Absolutely.
I just thought I'd throw that in.
Yeah.
If you are going to buy a supplement, look for ones that have a label on them that says USP. And those are ones that are third-party tested and third-party regulated. Oh. So there's a label that they can pay to apply for, the companies can, to have someone come in and investigate and test those levels. And it's not common to find that, but some of the brands will have that. So always look for a label to show that, because you're right, they're not regulated at all. So it's hard to know what you're really paying for, because they can be very expensive too. Right. So at least look for the USP label to make sure that if you are going to take it, that you're getting what you're paying for.
That is great advice. I did not know that. Thank you. Maybe before we finish, you can tell us a little bit about protein and how we might need to regulate the protein intake during the course of the day.
Absolutely. So protein can interact or can kind of compete for absorption with levodopa in our cinnamon. So protein, I think of proteins as a castle. So castles are built of all these different building blocks, and those are amino acids. And every protein, every castle looks a little bit different. And some castles work really well together, and some castles really don't get along very well at all. And so when we think about protein as a castle, so certain castles like meats, especially animal proteins, those definitely can, not necessarily in everybody, but in some subsets, it definitely can compete for absorption. So if you're having some struggle with your on and your off times, then usually my recommendation is to kind of rearrange those, especially those animal proteins, to the end of the day, when you don't have to be out and about and you don't have chores to do. Try and rearrange those to the end of the day. Now, on the other hand, there's some research, especially in Japan, they're looking at like plant-based proteins and how those might be castles that may even get along with levodopa. And so looking at different types of plant-based proteins like soybeans or like other types of legumes, or even like fibrous foods like quinoa, those may not have that same drastic effect that the animal proteins do. So kind of playing, if you are having some difficulty, you can try playing with that a little bit, seeing if going some plant-based for some of your meals, especially your lunch, as an example, may not be quite so detrimental as the animal proteins are.
Great advice. Thank you. All right, I want to talk a little bit about LSVT as it relates both to speech, swallowing, and physical therapy. So we had questions coming in as to what is LSVT? How can I improve the volume of my voice? How can I improve drooling? Can you give us a little synopsis of what that is? And really, like your whole career in this short.
So LSVT Loud stands for Lee Silverman Voice Treatment, and it's a great program. It's a highly intensive program. It's 4 days a week for 4 consecutive weeks, an hour each time. You have homework the day that you come see me. You have 2 sets of homework the days that you don't. And the great thing about this program is you are just targeting one thing, and it's to increase your volume. But what they found with that, just focusing on that one thing, increasing your volume, high intensity, working on the mismatch of your perception of how loud your voice is and how loud it really is, they have had all of these wonderful secondary effects, like it improves our vocal quality, speech clarity, prosody and intonation of our voice, facial expression, and then it's also shown to improve our swallowing functioning. So it's a really, really good program. Highly recommend it. Come see me. The deal is too that it has been shown to have really good results and staying power for up to 2 years.
Oh, wow.
So it's great to do the program, and then it's great to come back and see us, and same thing with Big, to come back and see us every like 6 months to 9 months to get just a tune-up, a reboost, and then send you back out again. That was quick.
Yeah. Thank you. That was fantastic. Is Big kind of in the similar vein? And I know there's more than just Big. We have PWR.
So I know people had asked questions, what's the best exercise for Parkinson's? And so Big comes up and Rocksteady comes up. But what I will say is it's more about a recipe. So the most important exercise is actually aerobic exercise. I would put that on the top of the castle, more important than anything else, because what we've seen is that aerobic exercise, when done early in the disease, can improve attention and improve thinking quality. And even when done later in the disease, it can improve memory. So kind of piggybacking off of that, our biggest concern really as the disease progresses is a respiratory dysfunction, right? So when we taper in aerobic exercise with allowed voice training, we're getting such good expansion of your respiratory system. And especially in this COVID world, I cannot emphasize enough how important it is to take care of your respiratory system with your voice and your breathing.
Thank you. Thank you so much. So I wish we had more time to talk about a whole bunch of other topics, but as you can see, Parkinson's is complex, and so we really do need to enlist the help of all of these subspecialists to really provide the most holistic and comprehensive care. Thank you to all the experts on this panel for their enlightening perspective today. So let's get up and get moving again. Don't forget to hydrate, or you can take a personal break, but I promise you are in for a treat coming up next. Paul McCarthy is a PANC board member and certified personal trainer, and he's going to lead us in our next movement break. Paul is a dedicated and passionate personal trainer, nutrition coach, and life coach. And his work inspires people with Parkinson's, cancer survivors, basically anyone who wants to keep in their best physical condition. He's also trained in Parkinson Wise, which you can learn more about by accessing the video link you received in your conference packet. All right, Paul, let's get moving.
Thank you, Dr. Chang, for that wonderful introduction. Here we are, folks. It's time to get up and get ready to get into some more movement here, right? We're going to really get ourselves stretched out this morning. We've had some wonderful information. Now it's time to go ahead and work that body, put those things into action, okay? So I want everybody to get up cautiously. Make sure that you're free of any objects because we're going to do a little stepping, okay? And we want to make sure that we're in a safe, free environment, okay? All right. So what I'm going to have you do, first of all, when you get up, if you need assistance in getting up, let someone help you get up. And we're going to, a little later on, just add a note, we're going to do this thing I call power up. It sounds real loud, but you're going to bring your voice to that. That's what I want to hear. I want to hear that voice, but that's not yet. Right now, I want you to get in that stance nice and tall for me. Put a nice bend in your knees for me, okay? Soft bend in the knees. Put your hips where your hips sit back just a little bit. Little tilt in your hips right here, okay? All right, put your hands out. Get your hands out for me, okay? Turn the palms in very slowly. Turn them back down. Turn them in. Turn them down. What I want you focusing on right now is your sitting posture and your hands staying out. They might want to tremble a little bit. They might want to drop, but you keep them up there nice and strong, nice and strong. Looking good, I'm sure. Come on back, nice and wide. Good. Come on back in. Push them up. Real quick, if they don't go all the way up, don't worry about it. Don't worry about it. Come on back down because we're going to do that a couple times. Stay seated. Nice soft knees right here, okay? Ready, right here. Let's go. Push out. Good. Make it work. Make the work. Come back in. Push up. All right. Come on down. Can you do that for me 2 more times? Let's go. Push out. Seated. Nice and comfortable. Not too deep. Come back in. Ready, push up, come on down. You're gonna go a little power up for me here. So we're gonna go out like this, and then when we come back in right here, this is gonna be our power up, and we're gonna say, power up, nice and loud. And we're gonna come back down, right? So let's go, let's push out, come on in, power up, come on down. Let's go, push out, come in, let's go, power up, come on down. Good. Bring your arms in. Go ahead and stand up and bring those feet back together. You know, I like that big movement when we come back in, though. So when you come back in from here, the next time we go out, try and make that big step in for me, okay? All right. Next move. Next move. I'm going to have you put the left foot forward just a little bit. Right foot out. I need your toes aligned with your knees, coming in this direction. The closer you are together, the more unstable you're going to be. So get out there in a nice stance for me, okay? All right. We're going to put our right hand forward, palm down. Left hand is going to be back from a side perspective. It's here, right? That's what we're going to have, okay? Just get in that and hold that for me right here. Now, focus on straightening your body up and pushing your fingers up toward the ceiling and pushing your arm back a little more. I know that's a lot of work. Absolutely, the muscles are saying, what are we doing? What are we doing? We're stretching, we're pushing, stretching and pushing. Come on down, relax. We're going to do that 2 more times, 2 more times. Ready, and let's go. Push the arm up, push the hand back, nice and strong. Hold that for me. And 5, 4, come on, push those hands up. 3, push that hand back. 2, 1, and stop. All right, we're going to get dynamic with it. I love movement, right? Big movements, right? This is what fights off that Parkinson. We know that. So we're going to do this. It's going to be here, and we're going to go into a switch right in here. Now, when you switch, you may feel yourself coming out of this switch and leaning over a little bit. You're going to really focus on this. This is your core. You're going to focus on this core, stand nice and strong so you don't tilt over, okay? So everybody get in this position right here for me. When I say switch, you're going to go just like this, okay? Ready, switch. 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 Now, we're going to add my favorite phrase. I love the power up. When I say go, you're going to say power up. Ready, go, power up, go, power up, go, power up. One more, go, power up. Good job, relax down. Step up, okay, big step forward. Don't give me the little foot forward. Okay, we know that's what happens. But once the body starts warming up, you're able to make those bigger steps. Switch out sides for me, right? We got a left and right side we have to work with. Left hand forward, right hand back. Ready. Switch. 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 That's 4. Switch. 5. Y'all ready for some power up? When I say go, you switch into your power up. Ready, go, power up, go, power up, go, power up, go, power up. One more, go, power up. Good job. Big step in, big step in. Good job, bring that step in. Awesome, breathe. Push it out. Breathe. Push it out. Good. We're going to do some big pushes. But first, we're going to start out rocking, okay? We're going to rock. We're going to push over to the right, hand over the top. Palm must face down when you're pushing over the top. Don't let the hand come to the front of your body, okay? When you bring it back down, I want you to bring this elbow back down forcefully. That back heel, if you can get up off the floor, that's perfect. If you're just leaning here and it's still flat on the floor, that's okay, okay? But if you can get that up, that's gonna work with this balance. Come back down, right? Let's stay to one side. Push, come back. Push, come back. Push 3, come back. Push 4, come back. One more time. Push 5, come back. Good job, breathe. Okay, come up out of that stance a little bit. Okay, steady yourself, take a nice deep breath. Push it out. Starting to sweat, starting to feel that? That's those muscles. They're starting to work for you. All right, here we go, going the opposite side. Ready? Push, bring it back down with force. Push, bring it back down with force. Palm facing. Push, back down 3. Push, back down 4. Heel, if possible. Push, back down 5. Good job. Stop. Breathe. Stay there. We're going to power up through this move. Power up is what it's about. Big, loud movements, okay? So we're going to push power up, come down, power up, come down. So we're rocking into these movements, nice and strong, okay? Ready? When I say go, you start your push. Ready? And power up. Go. Power up. 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 2 more. Power up. Power up. And stop. Breathe. One more time. Take a nice deep breath, okay? Take a nice deep breath. Hard to talk and breathe, but that's a good process right there, okay? Good. You're going to bring your legs together. This is checking on our stability, working with it. I know this can be pretty scary, okay? But this is what we need to work on. We're going to do a slight bend on the knee, the left side, and it looks like this. This is all we're doing right here. If you only feel comfortable moving the knees front to back, that's okay. I want you to lean with it a little bit, okay? Lean just a little. Lean just a little. Almost like you're doing an early Nordic skiing type deal, right? Real early, right here. Give me that for the next 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and stop. Open up your stance. This time you're going to lean, and you're actually going to lean and you're going to shift the body over. You are going to make sure, from a side perspective, your knees do not come out over your toes when you're leaning. So just lean to the side and get back to the center and lean to the side. Lean to the side. It's almost like those early days of dodgeball. Remember those early days of dodgeball? Right here, we push and push and push. Everybody start your push. Start your push. Ooh, breaking a little sweat here. That's a good thing. That lets me know my body really generating energy I want it to do. And 10, 9, keep shifting. 8, 7, you may give it some arm movement. 6, 5, 4, 3, 2, 1. and stop. That's in our hip complex. One of the things we know associated with Parkinson's is our inability to turn. We make these little small steps, right? We want to be able to take those steps, which leads us to the next movement, okay? Breathe, breathe. You got this. You are doing great. If you're still standing, you are doing great. And if you're ready to make this move, you're doing fantastic. All right, so here's what it looks like. You're going to stand nice and tall. You're going to put a soft bend in your knees. Okay? When you step, your toe and your knee is going to go in that direction. And your hand's going to come out to the side. You're going to clap your hand. You're going to bring it back. And you're going to step in. Okay? So once again, it looks like this. Step, clap, back, in. That's our move. Okay? We only have to do that 5 times. Then we're going to do it with a power up, and it is wonderful. Ready? So we're going to go out, clap, back, 1. Out, clap, back, 2. Out, clap, back, 3. Out, clap, back, 4. Out, clap, back, 5. Outstanding. Breathe for me for a second. Okay? When you're standing like this, if you want to move your legs a little bit, that's quite all right, right? That's our neural system working, right? It says, I want a little movement. I'm loving the movement. Let's go to the opposite side. Once again, get the hands up, okay? And it's our left side we're working with. If it's your right, it's okay, okay? We're going to step, clap, bring the arm back, step back in. Remember, we got to be mindful of how we're stepping and turning. That's the key, okay? Step, clap, back, in. 3 more. Step, clap, back, in. Now, if you can't go that far, I want this. Okay? One more time. Give me one more big one. Ready? Let's go. Out. Clap, back, in. Outstanding. Get yourself together. Go ahead and take a nice deep breath for a second. You are going to power move this move, and I love it. If you find yourself, when you come out here and you're hitting the inside of your arm, it means you're just not extending through your shoulder. Act like you're trying to reach for something with this hand so it claps. If you come here and it claps here, reach. So you can clap your hand. Come on back in. All right, let's go. Get into position. Everybody's ready. All right. We're going power moves. We're going to do 3 and 3. Okay. Going out to our right, then out to our left. When I say go, you're going to step, and I will power up when you clap. Ready, out. Power up, back, in, out. Power up, back, in, out. Power up, back, in. Outstanding. I'm telling you, that looks good. And I can almost visualize you doing it. Okay? Here we go. Last one. This side. Come on up. Nice and strong. Ready? Let's go. Out. Power up. Back. In. Out. Power up. Back. In. Out. Power up. Back and in. And stop. Woo! You ought to be pretty warmed up now, okay? All right, thank you for that. Each time you get ready to get up out of your chair, make some kind of motion to swing an arm, to move ahead. That's going to start your body with your movement. Don't just get up and start moving. Get up and help your body realize what's going on. Okay. So, how are you feeling now? You ought to be feeling pretty doggone good. Well, it is my pleasure to introduce the next session, lunch case studies presentation featuring motor fluctuations and dyskinesia. We want to give special thanks to Boston Scientific for sponsoring this valuable session, and you will absolutely get a lot out of it. So please, just like you did with the exercises, pay attention. It's going to be good. Please note, none of the speakers presenting here today received any honoraria for their contributions. In other words, not a coin, okay? They're here speaking on PANC's behalf, and we're loving it. Okay.
All right, thank you, Paul. I hope everyone's feeling energized from that movement break. Welcome back. So in this segment, I really want to tackle some of the most challenging motor symptoms in Parkinson's disease, motor fluctuations and dyskinesias. So to help me do that, I've invited some of our best and brightest Parkinson's specialists in the Sacramento region to help me weigh in on the management of these motor complications and talk about the indications for surgical therapies in Parkinson's disease. So first, I'd like to introduce my panelists for today. I have Dr. Ehsan Hadi. Dr. Hadi is a highly respected movement disorder neurologist at Dignity Health, and he specializes in the diagnosis and treatment of Parkinson's disease. Thank you so much for being here, Dr. Hadi. And next I have Laura Sperry. Laura Sperry is a nurse practitioner with me at UC Davis, and Laura has years of experience with Parkinson's disease, and in particular, deep brain stimulation. Thank you for being here, Laura.
Thank you.
All right, so thank you so much both for being here. Let's jump right in, and we're going to start with a case. All right, so here's a patient. Mr. T is a 48-year-old gentleman who developed a right hand tremor at rest, along with changes in his handwriting. His right arm and leg started to feel more stiff, and he noted he wasn't swinging the right arm while walking. He had no other medical issues except for long-standing constipation and depression. Upon specific questioning, he reported a decrease in sense of smell. His wife noted that he moved around a lot while sleeping, as if he was acting out his dreams. There was no family history of neurologic diseases. So on our initial neurologic examination, he was found to have a rest tremor in the right hand that disappeared when he was holding posture or when he was engaged in activities. There was decrease in facial expression, and his voice was very soft. Fine motor tasks were slower and less dexterous on the right side compared to the left, and there was no weakness or numbness in any extremity. He was able to stand easily from the chair and walk down the hallway without difficulty, although there was a decrease in arm swing on the right side. So that's our patient. So let's talk about diagnosis. I'm going to turn first to Dr. Hadi and ask can we make a diagnosis based on what you've heard so far?
Well, first of all, Dr. Mulhara-Cheng, thanks for inviting me to be part of this discussion. Based on the history that you have presented, there are some key features, and that's what we look for when we make a diagnosis of Parkinson's disease. The diagnosis still is clinical based, and so if we hear or see these some of these key features, that helps us make a clinical diagnosis of Parkinson's disease. And what you have mentioned there, slowness of movements, one of the main features that we want to see when making a diagnosis of Parkinson's disease. The resting tremor meaning tremor that comes on while the patient is completely relaxed, and slowness in movements, and some stiffness that we see, gait changes. So those are all features that we would like to see when making a clinical diagnosis. So based on what you have presented, I think the diagnosis is pretty clear for Parkinson's disease.
Okay. And there was a couple of other features as well. He didn't have any other medical problems, but this gentleman had years of constipation and depression. When we asked him, he had a decrease in sense of smell, and his wife had noted that he was acting out his dreams at night. Do you think any of those things are related?
So in Parkinson's disease, we know the process probably starts years before we actually make the diagnosis of Parkinson's disease, which is based on the motor symptoms that you just mentioned. But a lot of times what we call them pre-motor features, and they can range from loss of sense of smell, constipation, sleep disturbance, excessive sleepiness, having movements during sleep, what we refer to as a REM behavior disorder. So these features definitely can be related or can be signs of Parkinson's disease, which people can have years before they actually get diagnosed with Parkinson's disease or develop motor symptoms of Parkinson's disease.
Mm-hmm. So at this point, is there any other diagnostic testing that is needed, or is it purely clinical?
So it depends on the expertise of the physician that this person sees. But based on the features, personally, I would not recommend any additional testing. If I've ruled out on my exam, on the history, if there's any other symptoms that goes against the diagnosis of Parkinson's, definitely I would. But in this situation, it sounds pretty straightforward. So the diagnosis is clear. As far as additional testing, not at this point, but we do have the option of having additional testing, where one of the tests that we can do is called a DAT scan, DAT, or dopamine uptake scan. It looks at very deep nuclei or deeper areas of the brain where we see that Parkinson's comes from, and that scan helps us differentiate people who have Parkinsonian features from people who don't have Parkinsonian features. So it's a good scan if we have some ambiguity about the diagnosis. Let's say you cannot examine a person because of whatever reason, or there are certain medications that can lead to Parkinson's. So in those situations, personally, is where I would recommend getting that scan done.
Great, great. So what would be your initial therapeutic approach at this point?
So that's the approach has to be said, since Parkinson's is a multi-system disorder, so multiple parts of the brain and body are involved, so we have to have a comprehensive approach. And that's kind of individualized, depends on from person to person. This is a young onset Parkinson's disease person, so I expect that he's working, he's got a family, he's very active, and he needs to remain active. So for that kind of situation, it's a decision that we make with the individual and say, we ask them how much are the symptoms bothering them, how are they interfering with their day-to-day functionality, their job, and that will help us guide the treatment. But in general, there is obviously a pharmacological aspect of treatment, but there is also a lifestyle management as well, and that includes exercise, because we know exercise is so important with different changes in the brain that exercise can help with. Increased signaling in the brain, increased dopamine, the chemical transmission, and so on and so forth. Obviously, we don't have really strong evidence for that, but I think those exercise definitely helps with those situations. So exercise, as far as diet is concerned, supplements like antioxidants, stuff like that, and looking at their mood, looking at their sleep. So all these aspects have to be addressed when you're managing someone's Parkinson's disease. But going back to your medication-wise, depending on the symptoms, depending on the how the symptoms affect quality of life, we can start with some basic medications that can be as what we call MAO inhibitors. And we have a couple of choices in that, 2 or 3 choices in that regards: rasagiline, selegiline, sulfonamide. So we have choices. So it basically, without going into too much detail as far as what would be the first drug, I would say it depends on the person's quality of life issues.
I agree. Thank you so much, Dr. Hadi. That was really comprehensive. So going back to this particular patient case, let's say he did start on a monoamine oxidase type B inhibitor, and he had an excellent response. So what that means is the rest tremor improved, the right-sided stiffness and slowness all got better to a good degree. And his wife even noticed that there was some improvement as well in how natural his right arm looked when he was walking. Further down the line, this gentleman was started on carbidopa-levodopa, which is a very commonly used medication in Parkinson's disease. We have a lot of different formulations out these days, and we can talk more about that later. But the carbidopa-levodopa further improved his motor symptoms. However, the patient had one complaint. The complaint was that whenever he would take a dose of his carbidopa-levodopa, he would start to feel nauseous. So Dr. Hadi, maybe you can touch on how do we deal with this situation now? We've got medications that help, but also result in some side effects.
So that's a very good point, because not everybody gets it. But when people get it, it's very uncomfortable. They're already dealing with another condition, and now on top of that, they have to deal with the side effect of a medication. So how do we address that? One way that I usually start people with levodopa is to gradually increase the dose. And that sometimes helps with better tolerating the medication. If that still doesn't work, or if the symptoms still persist, then sometimes taking it with some crackers or with something soft like that can also help. We also have to address it. What is the reason for the nausea? Is it only medication related? Because sometimes nausea can come from, just like the body slows down externally with Parkinson's disease, internally also it slows down. So, is it the gut slowing down? Is it the stomach slowing down? And that can sometimes lead to nauseous symptoms as well. So we have to address it accordingly. But if it's medication related, usually I'll slowly start the medication, because levodopa has another component in it that helps prevent breakdown of levodopa before it gets to the brain. The brain loves levodopa, but the stomach doesn't. So that's why it's formulated in a way to have that chemical already incorporated in there, so it doesn't, or it prevents it from breaking down before it gets to the brain. Sometimes it happens still. So yeah, I mean, slowly increasing the dose, taking it with crackers, and then also sometimes we have to actually give additional medications to prevent nausea. That can be a variety of them that we know of. So if that's the situation, usually we'll have to add another medication.
What are some of the examples of what you might use in that case?
So what I will sometimes do is add more carbidopa to it. So levodopa, carbidopa, the original combination, add more carbidopa to it sometimes. Otherwise, I'll use sometimes Zofran to it, which is a pure nausea medication. Domperidone is another one, but I don't think so that's available here. So, those are our choices there.
Great. Okay. So now let's say we've given Mr. T some supplemental carbidopa in addition to his pre-existing carbidopa-levodopa, and his nausea is now alleviated. So he actually does well for quite a number of years. And so let's fast forward a bit in the timeline here. And on a follow-up visit a couple of years later, Mr. T reports that his medications are not lasting as long. So each dose of carbidopa-levodopa helps him, but he feels the benefit wears off before the next dose is due. So what are some of the strategies, Dr. Hadi, that you would employ to help address this wearing off problem?
So this is an expected course with Parkinson's disease, because initially, as the brain has reserves, dopamine itself has a half-life of maybe 2 hours or so approximately. But the brain can easily store it, and people can use it over time, or it works over time. But with the passage of time, as there's changes that take place in the brain and there's some degeneration, this capacity for the medication to last longer slowly goes away. And there are different ways to address that. One way is to obviously use your existing dopamine and maybe increase the dose a little bit to fill the gap. It depends on what kind of gap they're having, but if it's a wearing off effect where the medicine is not lasting until the next time versus sometimes people don't even feel the benefit of the medicine. So if it's not lasting long enough, sometimes increasing the dose before we switch to something different, that sometimes helps. Adding another medication can help with a slightly different mechanism. If all those options have been tried, then switching the dopamine to a longer acting formulation can also help, because that can have a little bit longer half-life, and we have a formulation for that purpose as well. Additionally, I mean, if it's an off and on kind of wearing off, meaning most of the times I'm okay, but once a day I'm wearing off, in those situations we have some very short or quick acting formulations available as well, and they are absorbed through different processes, and they can have a role in those situations.
Great.
And these are newly approved.
Excellent. Thank you. So let's say on follow-up examination, Mr. T is now doing better with regard to his motor fluctuations, but you're starting to notice some abnormal involuntary movements. So instead of being able to sit quietly, there's a lot of restless, fidgety movements. And our field would call that dyskinesias. So let's talk about any medication changes you might make in light of seeing some new onset dyskinesias.
So dyskinesia, as you mentioned, is an effect of being on dopamine, having Parkinson's disease, and then being on dopamine for within a few years people can get them. Not everybody gets it, but young people tend to get it more. And it can develop after a few years of being on the carbidopa-levodopa. First of all, first question we have to ask is the dyskinesia bothersome? A lot of times family members see the dyskinesia and they feel like, oh, things are getting worse. This gentleman or this person is not doing well because they're moving around or being fidgety. But for the person themselves, it actually may be a good state that they're in, meaning the medicine is working. That tells us the medicine is working, they're able to function better. But if it comes to a point, and about 20% or so of the people who have dyskinesia, the dyskinesia can be troublesome, meaning it can lead to balance issues. That's when I will intervene myself, is when they're walking and they're so wiggly that you worry if they're going to have a fall. So those are the situations, even though the person may feel like I'm okay, but I will intervene in that situation to correct that. Or if the dyskinesia is leading to abnormal posturing or pain, stuff like that. So if that's a situation, then the options are, first of all, we have to make a compromise sometimes, because you cannot have perfect of all worlds. You have to see, okay, how much of this dyskinesia is bothering me versus how much control would I like to have. And then first choice would be, is it possible to lower the dopaminergic medication a little bit? And sometimes that helps minimizing dyskinesia. If that doesn't work, then there are medication. There was a medicine for a long time, only medicine we had, to help suppress dyskinesia. And that can help in selective cases. We have a longer formulation of that medicine available now. It's called amantadine. And we have long-acting amantadine now, so it can be once-a-day amantadine. So that medicine has shown to improve dyskinesia when it becomes troublesome.
Great. Okay, so let's say we made some of these adjustments. So instead of regular carbidopa-levodopa, we used extended-release formulation, carbidopa-levodopa, and perhaps we may have added some extended-release amantadine as well. And so what happened with Mr. T is Mr. T did feel like each of those changes was associated with an improved outcome. So there was benefit. However, now we're going to fast forward some more years, and over time, he developed more and more difficulty with the motor fluctuations and the dyskinesia. So despite the medication changes, he started feeling like he was never completely on without dyskinesia. So if he was on, it was on with a lot of extra movements, or off entirely. And by off, I mean stiff, slow, frozen, very difficult to move. And so over time, the days started turning into a constant on and off roller coaster. And eventually he felt there was really no good on time without dyskinesia. And that's a challenging situation, and I want to ask nurse practitioner Laura Sperry to weigh in on when is it a good time to start talking about surgical interventions for Parkinson's.
Great, thank you. So we have two different surgeries that are available to patients with Parkinson's disease, and they typically start becoming part of consideration when patients have exhausted most of their medical options, their medications are not lasting as long, they're having more of the fluctuations, those periods of on or off, so basically functional and less functional parts of the day that we're just not able to fill in the gaps, or they're being limited on their therapy because of the side effects from the medications. So the two options that we have, one is deep brain stimulation, which you had an earlier talk on. And just as a reminder, this is where we put electrodes into the brain. They tunnel underneath the skin behind the ear, and they connect down to a neurostimulator, very much like a cardiac pacemaker that is in the chest. And that neurostimulator is a mix of a computer and a battery that helps send signals up to the brain and can help control the motor symptoms of Parkinson's, the tremors, the slowness, and the stiffness. For
the other option is something called the Duopa pump. And this is an intestinal version of the carbidopa-levodopa medication that you're familiar with from the oral formulations. And this pump is where we put a hole that goes into the, a PEG tube that will go into the stomach. There's a tube that will go down into your intestines so that we can deliver the intestinal form of the carbidopa-levodopa more directly. And this option may be an option for individuals who are not candidates for deep brain stimulation. Perhaps they have medical problems or cognitive concerns that may make them a slightly higher risk patient. Or in general, the idea of brain surgery is not something that they're considering. And the Duopa would then be an option for them.
Great, thank you. So in this particular situation, how would you advise Mr. T?
So the discussion definitely is a decision that's made with the provider as well as the patient. So a lot of it comes down to which option is the patient most comfortable with, as well as what option is the provider most comfortable with. So what do they have the most experience doing? And then what type of lifestyle options is this individual looking for? And do they find the idea of an electrode in the brain and a battery that will need to be changed intermittently? Is that something that they feel like they can work with? How would the idea of having a pump that would be very much like an insulin pump be, where they would have a cartridge that they would change out every day? So you have to talk about the options and the logistical components, as well as, because they both target the same options. They both target those fluctuations.
Okay. Dr. Hadi, maybe you can weigh in and tell me, how do you counsel patients on making this surgical decision?
So both of these are advanced options for management of Parkinson's disease. Usually I'll talk about both these options after a few years of people having symptoms, or when they begin to have these dose fluctuations, as we call them. And based on their approach, that's how I would recommend one way or the other. But other than that, what we usually look at is that, first of all, how responsive they are to medication. That's our first step of screening people who are going to be good candidates, because we want to only refer people for these procedures because these are invasive procedures, both of them, one more than the other. So for somebody to go through that, they have to be nicely responsive to treatment. So we go through that screening process, which Laura does more than I do, I think. Once we go through that, then we assess how well will they respond to each treatment, and then have that discussion with the individual. Sometimes when we see a little bit more, people have a little more difficulty with memory and stuff, sometimes that will help us lean more towards the dopamine pump versus surgery, because with surgery you need a little bit more involvement as far as managing and the programmer. So that's how usually we have that discussion and then help them decide. But some people, they have their own, they lean more towards one or the other without any reason.
So it's clearly a team approach. You involve both the patient, the family, all of the providers. Laura, you're very involved in the candidacy evaluation for these patients. So not everyone who wants to have surgery perhaps may be good candidates. So can you tell us a little bit about the candidacy process, and what are some of the steps that we use, at least at UC Davis?
So at UC Davis, individuals that are coming through the surgery process will go through a very rigorous evaluation. They will always start with their movement disorder neurologist making the initial referral. They will meet with our surgeon to have a discussion from the surgeon's perspective if they think this individual is a good surgery candidate. They will also undergo what we call on and off testing. So we will videotape them off of their medications so that we can see what are your core symptoms with Parkinson's. And then we'll have the patient come back on their medications and videotape and see how their response is, which symptoms get better when they take their medications. And this becomes really important, particularly for deep brain stimulation, because the individuals that are going to respond the best are those individuals that have dopaminergic responsive symptoms. So in particular, the tremors, the slowness, and the stiffness. So if they feel better on their medications, but we're not seeing a significant change in their motor symptoms, they may not get a strong response after surgery. And so this will help guide our recommendations of whether or not we think this is an appropriate path to follow. And then the other piece of this is we will have individuals undergo a very in-depth neuropsychological evaluation, and this can be a several-hour process. We want to get a better understanding if anybody has any existing cognitive concerns, any mood concerns, any psychiatric concerns before we move forward with our surgical evaluation. And then the last component of that evaluation is an MRI. So we want to get a peek behind the scenes. Is there anything that the surgeon needs to know about that may make implanting those electrodes a little bit more difficult?
Thank you, Laura. So it sounds like some of those things are a little bit intimidating and a little bit stressful. So tell me more about this neuropsychological testing. What does it entail?
So it is probably one of the more in-depth evaluations people have had at this point, and certainly is something that that intimidates most people coming through. Even those that come through with flying colors tell me afterwards, oh, I did awful. So don't make too many judgments as you're coming through it. But it's an opportunity for the neuropsychologist to, one, get a really in-depth history so we can understand what type of experiences, what type of education, mood issues, psychiatric issues that these individuals may have dealt with in the past. They'll have you do a variety of tests to help get a better idea of are there any cognitive, are there any memory issues? Are we beginning to see some what we call executive functioning concerns? Mm-hmm. And if there are some concerns, it will help, the results will give the neuropsychologist an idea of, are we dealing with changes that are solely related to Parkinson's? Are we beginning to see a dementia or an Alzheimer's? Are there other types of issues that are coming into play? And that may make a difference of whether or not this individual would have a positive response with surgery afterwards.
Right, because it sounds like you're saying that those people may not have as good an experience with
Correct. So if we're beginning to see the onset of dementia or an Alzheimer's, actually going through brain surgery could speed that process up more than the natural course. And so even if somebody's tremor gets better, they could have a bigger decline in their cognition than they would otherwise if they had just proceeded without the surgery. And so that comes to that weighing out of the pros and cons, of the benefits and the risks of moving forward with the next therapy.
Yeah. The other piece of the candidacy evaluation that maybe was a little intimidating is the off testing. So does that mean you have to be totally off your medications? Every single one?
It is definitely everybody's least favorite day to come into the clinic. It's a really hard day. And so for those that have been through it, those who are considering it, I thank you very much. It is a really important day for the DBS team to have an understanding of what are you dealing with at home, what are your core symptoms. So it's a very informative test, but it is certainly a challenging one to go through. Different DBS centers may have slightly different guidelines. At UC Davis, we have you stop your Parkinson's short-acting medications 6 p.m. the night before, and your longer-acting medications will actually have you come off 3 days before, 72 hours before. So it can be a challenging day because most people have not been off of their medications for many years, so they really don't know what they're like. Some individuals come in and say, this is not what I'm like at home, I'm usually much worse, and they're doing much better than they would have thought. And other people who would normally be able to walk might need to come in a wheelchair. So it can be a very challenging day. As soon as we get through the videotape, we will get people back on their medications and try to get them back to a more comfortable state as quickly as we can.
Yeah. So as difficult as it is, I know we've had some cases in which we do the on medication and the off medication testing, and they're pretty similar.
Right.
So what does that mean for their candidacy?
So it throws some questions of whether or not deep brain stimulation in particular is the right step to go forward. So we can go through all of this. There's a very in-depth workup and then an in-depth process to get through surgery, and then these individuals might fall flat on the other side. They're just not going to see any of the benefit that they were hoping for this, and that can be very disappointing. And then they took all the risk on without the benefit of the surgeries. And so the individuals that will respond the best are the individuals that will have a more robust response to their medications. Now, there can be some exceptions because sometimes we don't see a difference, but it's really because their medications aren't not maximized, because they can't take them, because their side effects are so awful that they're not able to get up to a therapeutic
level. And so there's not really a difference between on and off. And so then we have to dig a little deeper in the history of when you have taken medications in the past, did you notice an improvement in your tremor? Have you had some positive responses on your movement that maybe you're not getting anymore? That might give us a little bit more clear understanding that they still are a good candidate, even though if we're not really seeing the clear numbers in there. So there can be a lot to take into consideration with that final decision.
Yeah, and that's a good point, because sometimes when you're bombarded by side effects, you kind of forget what the benefit was of those medications, and that's really important, it sounds like, for you to take into consideration when we're deciding whether or not they're a good DBS candidate.
Yes.
Good. Thank you so much. When you are counseling patients, Laura, with regard to, let's say they've made a decision to go forward with deep brain stimulation, we have a lot of options and a lot of choices, and I feel like the field is getting more and more complicated for patients, but that's why we're here. We're here to really help navigate through. Maybe you can break down what some of those choices are, starting with rechargeable or not rechargeable.
Yes, so the last few years have been very exciting within the deep brain stimulation field because there's been so many technological advances, which is definitely making our job a little bit more challenging as there's a lot of nuances. But at the core basis of that neurostimulator that's implanted in the chest, some individuals it could be in the abdomen depending on what else they might have implanted. Is the traditional battery is what we call a primary cell battery. So this is a battery that would get implanted and it's a set and done. So it is in there for 3 to 5 years. Sometimes it will last longer, sometimes it needs to be replaced a little bit earlier depending on the setting somebody's using, but it's something that they don't have to worry about until their battery needs to be replaced. It is something that needs to be monitored intermittently. So if you change providers and you don't have somebody monitoring your deep brain stimulation, you're at risk of that battery depleting without somebody monitoring it. So we need to make sure somebody's staying connected with a deep brain stimulation provider over the years. But another option is if individuals are looking for something that is longer lasting, there's a rechargeable option. And these options that are out in the market now are all approved for 15 years. So they don't need to come back in for surgery. They might be able to get through several batteries without having to come back in, whereas if they had that primary cell, they may have needed 2 or 3 batteries during that time frame. But these will be batteries that they will have to take responsibility to recharge. And depending on the companies and the device that they're using, they might need to be charged every day, or they might need to be charged about once a week. There's some variations and some variations in sizes, but both great options.
Yeah. So that does entail another surgery, though, if we are going to replace a battery.
Yes. Yes,
What's that like?
And that sometimes is one of the reasons that some people will choose to have that rechargeable is they just, the idea of having less frequent surgeries, less anesthesia over their lifespan can be really attractive. So if they feel if they can take on the responsibility of charging their system, or they have a caregiver that can help them with that, then that might be a really good option.
Great. Maybe you can tell us a little bit about some of the other features, the new features that are available now in terms of the DBS options.
So currently we have 3 companies that are to market, and all of them, we have Medtronic, Boston Scientific, and Abbott St. Jude, and then AbbVie, which is the Duopa company. All of these companies are part of our exhibitor hall. So on the virtual booths, you can go into any of their exhibit halls and get an opportunity to see their equipment, ask them more direct questions, and get more information. So you can get more specifics on their vendor booths. But specifically with the 3 deep brain stimulation companies, the general equipment is very similar between them, but they've all modified the technology and with different approaches. So traditionally on the electrode, on the lead, there's 4 electrodes. So the lead is placed in the brain, and there's 4 layers of electrodes. And we can push, when we turn the stimulation on, we're pushing the stimulation out in all directions. And the challenge has been that if that lead is a little bit too close to other structures in the brain, it could cause side effects. And so what has occurred over the last years is the companies have developed these directional leads. And coming this spring, all 3 companies will have a directional lead that will be available. And with a directional lead, if you think about this, you take a piece of pie and you cut it into 3 pieces, you can basically turn on or off different segments of that stimulation. And so you can steer the stimulation field to move away from structures that might be causing side effects, or to move more directly towards the part of the brain that you think is helping to reduce some of those symptoms. So that's probably been one of the biggest changes. And then within that, with the newer batteries that are coming out, there's been some structural changes, so the edges are becoming a little bit more contoured. We're hoping that we'll see less tissue erosion, less irritation from the batteries that might be irritating the skin and putting up people at risk of infection. They are hopefully becoming a little bit more comfortable as the newer designs are coming out. There's some new programming features in there too, so we have some expanded abilities to modify some of the parameters that we change that can reduce some of those side effects that often can limit our abilities with deep brain stimulation. And where the technology is moving towards in the future, there's some new technologies that are coming out that are trying to take a little bit of the guesswork out of programming, which can be quite lengthy. As any of you who out there may have deep brain stimulation know, the visits can last an hour or more. And what they're looking at is being able to have more adaptive deep brain stimulation down the road, where the system can garner brainwave activity and give us some more guidance. So we have some more objective measurements to help us better target the stimulation. So there's a lot of changes that are available to us right now, with a lot of technology that's going to be continuing to progress.
I think that's so exciting, right? Yes. Because wouldn't it be great if the deep brain stimulator knew that I was speaking and needed my maximum vocal projection ability, not moving, right? So I don't really need all of the mobility and the improvement in stiffness and slowness. I just need my voice. But then if you go and play tennis, you're not speaking at all. So you can turn it up and really give maximal motor benefit.
Yes.
Right? So I think that really is the future, and I'm really excited about the adaptive technology that's on the horizon. Dr. Hadi, you have experience with patients who have had the Duopa pump, and maybe you can tell us a little bit for our audience what it entails in terms of the procedure and how it works. What will they need? They kind of need a battery of a different kind, right?
That's right. So Duopa pump basically is dopamine, but it is slowly infused using a pump that hangs on the waist or somewhere, and the tube goes into the proximal part or just past the stomach, because that's where we believe the best absorption of dopamine takes place. And so it involves basically having to see either a radiologist or a gastroenterologist who will first assess you and see and then basically it involves putting a very special tube that goes into that area. But before that, you have these people need to be screened, and this is basically, first of all, we need to see why do they need it. I mean, this is one of those long-acting dopamine therapies trying to mimic brain's own slow release process, and in turn helping minimize dyskinesia with improvement in motor symptoms of Parkinson's disease. So it's a stepwise process, and then we have to see if they are able to manage this pump, or if they have a family member or somebody who can help manage this pump. So it requires a few screening steps, but that's basically how it is. And then once it's placed, then after that people get these dopamine cartridges that are placed in this pump, and that has to be changed every day. The infusion starts in the morning, lasts up to 16 hours, and after that it stopped, and people take their own oral medication at night, so that can help them through the night. In the morning the infusion starts again. So it does require some manipulation of the pump, so that's why we have to see if a person or a caregiver or a loved one can help manage those. So a few steps are required there.
It seems like for both of these interventions, it's really helpful to have a care person or a family member or someone who can help navigate. Laura, it sounds like for deep brain stimulation, it does involve a lot of visits, right, to a specialty center who can do this programming on a regular basis, and also for the Duopa pump. So both of those, that's important to note, I think. With regard to Mr. T, our patient, do you think that these surgical interventions would improve his primary complaint? So really what it came down to in the end was motor fluctuations and dyskinesias. Do you think he would get benefit in those challenges?
Yes, just off of the case, he sounds like he'd be a really good candidate. Specifically with deep brain stimulation and as well with the duopa, these therapies can offer more consistent on time throughout the day. So those ups and downs that people have as their medications are wearing on and off will still be there a little bit, but they'll be muted out. And so they'll have more consistent on time throughout the day. So what we usually counsel individuals when they're trying to decide, is this something that they want to go forward to, if they feel that it would be a success for them to have more of that functional time, and that if they just had a little bit more of that without the troublesome dyskinesias, then these can be appropriate therapies to go forward. If they feel like how they are when they're on is not going to meet their need, maybe because they have severe balance concerns or other issues, then there should be a further discussion about what's really bothering them and what types of therapies would match up with that.
Yeah. One of the questions that comes in quite often is, does this take the place of my medications? Will I still need to take medications even after I go through deep brain stimulation?
Yes, so you may run into the rare person here and there who has stopped their medication, but that is definitely not something that we advertise, and it's not a goal of these surgeries. So you will, some of it depends, there are a variety of locations that we can implant the lead, and one of them more than the other can help us reduce more medications. So we can sometimes reduce up to 50% of medications, but people will still need their medications. And particularly with deep brain stimulation, this therapy addresses the motor symptoms, the tremors, the stiffness, the rigidity, the slowness. It does not help with all those other non-motor symptoms that the medications help. And so as we start reducing some of those medications, sometimes we'll find some of those symptoms will begin to flare up. And so we have to find that happy medium of the best medication balanced out with the best amount of surgical therapy.
Yeah, I think that's a really good point. You know, sometimes it's such a mental effort to go through with something like brain surgery, that the expectation might be then to, oh, this is now going to take the place of all of my medications. And I've definitely seen in my practice, I'm sure yours too, where the withdrawal of some of that dopaminergic therapy is really associated with kind of unmasking of other issues like apathy or depression, right? Because sometimes the medications are kind of inadvertently helping with those too without us even realizing it. So gosh, there's so much to consider. It's a really, really challenging decision, but I encourage all of you to have these discussions with your movement disorder team. So thank you again, Dr. Hadi and Laura Sperry, for your insight and perspective in tackling some of these really challenging motor complications of Parkinson's, namely motor fluctuations and dyskinesias, and how they relate to our surgical options for therapy. So I now invite Sean Tracy, President of the Parkinson Association of Northern California, and Barbara Fleck, Executive Director, back for some closing remarks.
Thank you, Dr. Chang. Thank you for that introduction. You know, before we wrap things up today, I want to welcome Dr. Mark Damison with a message from the California Parkinson Disease Registry. Those of you who were able to attend our September conference with the registry, Dr. Kandar was there with Dr. Damison talking about the value of the data. If you haven't seen it, it's on the PANC website, so please go back and take a look at that video. And again, thanks to Assemblyman Nazarian out of the San Fernando Valley, who sponsored another year of data collection for the Parkinson's Disease Registry. Mark will talk to you about the registry, and again, I want to emphasize, as I did back in September, CDPH has been an amazing partner. They are really interested in the Parkinson community, and if you need something from them, reach out to PANC, reach out to them directly. We're going to get you some answers. So, Dr. Damison, you're up.
Thank you, Sean. It's my pleasure to be here. And thanks to all of you who joined us last month to learn more about the California Parkinson's Disease Registry. To recap a little bit, and as you all know who are there, the registry is an important tool for increasing the knowledge base of this complicated disease. We, as the California Department of Public Health and the California Parkinson's Disease Registry, look forward to more partnerships with PANC, and will continue to share our findings with you as they become available. I invite you to watch the video at any time on the PANC website. That is www.panctoday.org. The video will be available on the website until December 31st of this year. And also stay tuned. There will be more to come from the registry in the future. And now, back to you, Sean.
Well, thank you, Mark, Dr. Damison. Thank you for that video presentation. And again, the partnership that CDPH has created with not only PANC, but the entire Parkinson's community, medical providers, data teams, electronic record teams. You guys are awesome. And then I want to thank all of you for coming today. I'm going to give you a big virtual hug. I can do that as president. Barbara flexed that I could. I'm going to give you a high five, virtual high five, give you a fist pump. I'm going to tell you to power up, just like you heard, because that should get you really continue your enthusiasm for the Parkinson and the journey ahead. This is a full day of information, inspiration, knowledge sharing. I hope you learned something. I hope you really took something away and said, I'm going to follow up with that issue. And I hope you spend some time looking at the exhibitors' booths and be thankful to our sponsors. Without them, this wouldn't happen. Without them supporting all of this, we couldn't be here with you today. And again, I'm going to look for Barbara to talk to us about what's in store for next year's conference, but I'm going to be pushing for in-person, virtual, and over 1,000 people right here in Roseville, California. So Barbara, tell us what's up.
Thank you, Sean. And you don't want to miss next year. We are really excited about our keynote speaker, Mr. Jimmy Choi, and I'm going to let him tell you about it. So he has a special message for you here.
Thank you, Barbara. Hello, my name is Jimmy Choi, and I'm so excited to be able to meet you next year as the keynote speaker at PANC's 2021 Educational Conference on Saturday, October 23rd, 2021. In 2003, I was diagnosed with young onset Parkinson's at the young age of 27. You know, like many others, I immediately went into denial and ignored my progression for the next 8 years until one single event sparked a change. Now that change led me down a path that empowered me to go from walking with a cane to running a marathon, qualifying 4 times for American Ninja Warrior, and just recently breaking the Guinness World Records for the number of chest-to-ground burpees in 1 minute. Now, today, I travel the country as an advocate and a fundraiser while speaking to the Parkinson's community about my experience living with Parkinson's. My hope is to inspire others living with Parkinson's to join a movement to use exercise and fitness, no matter your ability level, to live your best life. I am looking forward to seeing you in 2021. Now, back to you, Barbara.
I can't wait to hear more about his experience and the message he has for us in the Parkinson community next year, which we are really sure we're going to be live next year, so please plan on being with us. We will be at our new location, the grounds at the Placer County Fairgrounds in Roseville, a beautiful building. Please join us Saturday, October 23rd, 2021. So now that we are at the end of our conference, I want you to know that this website will remain open until December 31st. Feel free to come back at any time to view the video or to visit any of the exhibit booths. We will be announcing the winners of the scavenger hunt on our website at panctoday.org, and we will contact the winners personally. So please send in your scavenger hunt codes. Thank you for coming. We'll see you next year. Bye.